Let's go ahead and get going. I'm sure others will join as time goes on here. But no, I think Mitch, thanks for sharing that information because it really emphasizes the value proposition here and the synergies, across a number of efforts. And of course, I think collaborating and standardizing, will really help in this effort. And in that regard, and I do there are four people who I want to have an opportunity to just welcome the rest of you to this call. Ron Waxman and I are the co-chairs for this SHARC initiative, but really, I would consider Mark Samsky and Mitch Krukoff, to be, really co-chairs, right along with us because, they're putting in a tremendous amount of effort, with us in terms of organization of this effort. I've had the privilege of being involved with a couple of other academic research consortium initiatives previously in heart failure and in mitral valve disease. Mitch has far more experience, I think, having been involved in virtually all the ARC initiatives, and he can speak to that as well. But personally, I think the value in this initiative is almost immeasurable. An opportunity to standardize definitions around the population, around events and endpoints and other key parameters that are measured in these trials, really to promote some comparability across trials, across registries, and so on and so forth, to maximize our learning from studies in the field. And I'm really excited about today because this represents, sort of a major beginning. Although, as you'll see, there's a lot of work that has already been done leading up to this meeting to create some initial proposals, some initial proposed definitions, to be vetted with all of you. We really want your input, and that vetting process and sort of revision process will continue over the next few months and will culminate in a follow-up meeting in which we'll hope to develop a consensus around each of these definitions, for publication and get this out there, into the world, and hopefully, many who are working in and performing trials or leading registries in the shock space, will begin to adopt these standardized definitions to meet some of the goals that were aforementioned. So with that, let me ask Ron to make a few comments if you would like, and then, maybe after that, Mitch and Mark, and then we'll just dive into session number one.
Yeah, good afternoon. I'm going to yield my time to the topics that we're going to discuss. I think there is a lot. This is a huge team effort. I view this as a milestone that we get together. And without further ado, we should dive into the program to make sure that we accomplish as much as we can for the 4 hours minus few that we already behind. So
yeah, exactly.
Take it from here.
Yeah, Mitch, Mark, go ahead.
Couldn't agree more. Thanks everyone for being here. Ready to get to work.
I do have to say that the reason today is going to work is that there's been an incredible amount of work done behind the scenes. And this is not how we'd like to do it face to face, but our programs have survived the Zoom mode and the pandemic largely by having smaller SWAT teams who are willing to get that work done. So I'm really looking forward to today.
And just one thing, CRT will happen. It's going to be in person only. There will be no hybrid. I know you're laughing, Mitch, but
I am so with you, Ron.
I guarantee you,
I have tears in my eyes. But
it's gonna be in person. Those who can make it will have it. It's gonna be a big meeting. I have a lot of international people that excited about opening the border on November 8th, and they make sure that they will be there. I guarantee they will be only. It's gonna be only in-person meeting, February 26th.
Fantastic. Okay, well, with that, let's launch straight into it. So session one is on definition of cardiogenic shock for clinical trials and registries, really focusing on, entry criteria. How are we defining cardiogenic shock and maybe its various forms. And Ron and Sean will lead this discussion. And really we'll have sort of a consistent agenda through each of these sessions with a brief about 10-minute presentation from the leaders of each of these sessions, followed by 30 minutes of open discussion to collect your input for the next stage of definition development. So Ron, Sean, why don't you jump into it? I think we should get your slides projected and get going.
Yeah, Sean actually worked very nice on the presentation. It was a work of Sean, Alistair, and myself, Dave Moore. So I let Sean to do the presentation. If you can share your slides, Sean.
Sure. I submitted my slides. I assumed they were coming up. Is that the case, or should I pull up my PowerPoint and share screen?
Go ahead and share your screen, and if you have any difficulties, we can pull up the backup slides, if that's good.
Okay. Hang on a second here. I'm just opening it up.
Yeah, just for everybody, I think that's going to be the MO through the day. So you should be empowered to share your screen if you have your PowerPoint open, ready to go. If there are any troubles, Simia has the backup slides, and we can go from central.
I see your computer, not the screen.
Yes. How's that?
Perfect. Yeah.
Okay, perfect. Sorry for the delay. So as Ron alluded to, I wanted to thank the work that Alistair and Ron put into this, and also the collaboration with Dave Moore and his group in SHARC too. And the reason is that we collaborated is that we felt elements of cardiogenic shock definitions were interrelated. In addition to just defining what shock is, you can't define it without saying something about acuity and staging. And then once you develop acuity and staging, there's the phenotyping. So the focus of us, as we did divide it up, is that we're going to have the shortest presentation, I believe. This is going to be the domain of working group 1. And although some of you may talk about talk about BIV or univentricular shock, that is in Dave's group. So just maybe to help focus the discussion. So it was difficult actually to come up with definitions of cardiogenic shock. And in the end, we settled on 2. And we felt that a unifying definition wasn't practical for clinical care, or for perhaps more for less parsimonious registries, because at its core, we felt at the top, it's a cardiac disorder that results in both clinical and biochemical evidence of sustained tissue hypoperfusion. The trouble with this is that if you're going to enroll someone in the trial, you really need to maximize the internal validity of that trial and to make sure you're only capturing cardiogenic shock and not just what people believe is cardiogenic shock, which could be fraught with issues. So then we came up with a parallel definition for trials and registries. It's a cardiac disorder that results in hypotension, and we do have a need for vasopressors or MCS to maintain that blood pressure with evidence of hypoperfusion. I'd like to highlight that there is hemodynamic criteria there with a cardiac index less than 2.2. We recognize that it would be ideal to have it in all patients, but depending on the registry read, somewhere between 25 and 50% of cardiogenic shock patients get a PA catheter or a non-invasive cardiac output monitor, so it's not possible. The second issue we want to acknowledge is that drawing a line with blood pressure in the sand can also cause problems. It may underrepresent normal tensive cardiogenic shock or less acute forms of cardiogenic shock, but that is with the goal of population. You can also see here that we have hypoperfusion criteria that involve one of the following, and I think these will be familiar to all of you because they were taken from seminal randomized control trials. Now, acuity or the staging of shock, what I have up here are simplified criteria based on the SKY criteria. This may change in the coming weeks as the SKY group has been working on slight revisions, but I don't think it's going to fundamentally change things in a huge way. But we do have some simplified criteria on the left. And for registries of trial that need more granular staging criteria, we do have the option of a more descriptive table here that can that study coordinators or site PIs can use to help assign the right staging code for those who are less familiar with it. So that is the presentation, perhaps the shortest of the day, and maybe the one that may generate the most controversy or questions. But we're happy to take any feedback on our.
Yeah, fantastic. Thank you, very much. I think the clarity of your presentation is excellent, and that's good because now we can open it up for discussion. And really, I want to encourage everybody to weigh in here. I'm, interested, or I think we're interested in, views from, other clinicians and investigators, industry, FDA is represented in this group, and others. And it would be good to really hear from, all of the stakeholders about what you think about the straw man that's been put forth by Sean and Ron and Alistair and others. So who wants to jump in first?
Yeah, let me start. Two people I'd love to join in. One would be Alex. I think I saw Mabaza is on the call, and or Alistair, to comment on the degree to which these criteria, ARC is not just US. We're very attentive to US regulatory practical requirements. That's what ARC was founded to be, but these days we're a global community, and ARC certainly is a global community. So does this fit European theater trials and definitions, Alex? And then if possible, to follow Chuck Simonton from an industry perspective, are these categories useful? Does it resonate? Again, the goal here is pragmatic, is practical, that these are useful to advancing evidence for device evaluation. So Alex, are you on?
Yeah, I'm very sorry. I am on a train and it may be noisy. Everyone first, and really I'm so honored to participate to this meeting. Now present since many times. What Sean did in his previous slides, I think we would agree. Maybe one thing that we see now more and more in Europe is the response to therapy, and I guess that in any of those stages, if there is a response to therapy, let's say to vasopressor, inotrope, whatever, even MCS. The question is whether this may change the category. Then we should explain that this categories is really stage, let's say in the initial risk stratification, but this can move at least with the response to therapy. What do you think?
Great. Chuck, have we got you on the horn?
Yep. Yeah, I'm here, Mitch. I think this is a really good fundamental place to start. Good work, by the team, and just getting this out there and getting some pretty standardized definitions. I mean, these are the definitions that we're going to be using in our trials. So very consistent, so that hopefully an industry, sponsored randomized trial like Recover 4 can be consistent with and really incorporate the work that you guys have done at CSRC and the SHARC group between Bill and Ron and others. This is really great work. It's interesting. You may have heard Naveen Kapoor present a lot, of course, on Sky shot classes, and he's educated me a fair amount. When you look at how different institutions like the SHARC Working Group Registry versus the Mayo Clinic versus other consortiums which have tried to interpret the SCI SHARC classification. They do it in it's slightly different across different registries as to how they actually define classic, because it leaves it open to either vasoactive or MCS support. And so we need to probably have a little more discussion. Maybe we want to refine this a little bit more to be a little more, maybe breaking the classifications down a little bit more so that there's a separation between SHARC requiring vasoactive vasopressors versus SHARC requiring MCS support, because the usual escalation, and this is in 2016, I think is when it was, there's an ACC guidance document for the management of SHARC that kind of starts with the definition you just described, and then vasopressors and inotropes, medical therapy, and then if you continue to have hypotension, organ hypoperfusion, lactate going up, you then escalate to an MCS. And in general, the algorithm is you go from a balloon pump, and then if that doesn't work, you go up to like an Impella or even ECMO with more advanced, more potent MCSs as you go from B to C to D to E. And in general, that's what's happening. But to make the definition, the class C, SCI SHARC class C, be defined by actually an action rather than a clinical condition of the patient is gets interpreted differently, right? In different registries as to whether a vasoactive agent qualifies or MCS, the use of MCS. Because in the SHARC working group, class C is actually defined by the use of MCS in their definition, which obviously is consistent with the SCI definition. So I'd love to hear some discussion on that, Bill and Ron and others, as to whether this should be refined somewhat into, C1, C2. I know Naveen has talked about breaking these down into subclasses, C1, C2, D1, D2, and then moving up toward E, just what people think about that, just for the slide that's up here right now. I won't go back. I think the definition of SHARC is pretty clear, and the slides up to this are pretty clear. It's just a matter of getting this definition as, as specific as possible in the database.
Maybe Sean and Ron, I can ask.
Maybe I'll take that first.
I think that Chuck, your points are very good ones. And I think it's important for us to think about from the get-go whether we think really we should just adopt the new SCI SHARC staging that will be developed, or whether we should be doing something different for SHARC. And if we are doing something different for SHARC, how should it be different, and why is it different? I think that's a discussion worth having, because I'd say one thing that is important for SHARC is that this is aimed at being useful across a variety of registries and trials where you might not, there may be a registry that doesn't have any MCS in it, and we would still want the SHARC definition to be able to apply.
Yeah, I agree with Dave. And as I put in the chat box, I think there are many of us on SHARC that are also co-authors on the new SCI paper, but that information is embargoed at this point, so it's not appropriate to share widely. But we're willing to pivot if necessary. To Chuck's first point about whether MCS or vasoactive should be split out, I think we all recognize that many of us practice in an incremental fashion, that the sickest patients are more likely to get MCS. But we also have to consider that practice patterns may vary, and some institutions may be very aggressive with MCS early on compared to others who may not even have an advanced MCS device on the shelf. So in an effort to make this more international and worldly and applicable across a variety of centers, that's where we may sacrifice a little bit of that granularity to to try and mitigate some of the practice pattern differences between hospitals or even countries.
Maybe I'll chime into here with several concepts. Number one, I think this is a definition to be used in clinical trials and clearly to document the status of the patient. It's not to determine a treatment. It can be correlated to something which we're going to discuss later today, the status of the patient to be able to give us a consent form. Obviously, when you're in E, it's going to be different that you're in A or B. But I think the issue is more to get a good description. So later on, when you do the sub-analysis of the clinical trials, you can determine whether this patient was started on vasopressors or on mechanical support. You have all this information, but we don't, I don't think that we want to dictate any therapy here. This is just basically taking a snapshot, a picture of the patient as much as we can describe it. And they're all going to be in some sort of shock status from the pre-shock to the full extent of the shock. But the key issue is to document the status as they get into the study, and from that on to try to see if we can compare between the different groups in the different trials, et cetera, et cetera. So for that perspective, I think it's very important to detail as much as we can the state of the patient, but not necessarily to determine any therapy. And I can understand, you can do C1 and C2 and C3. It will be documented. It's not that it's not going to be documented whether the patient is on vasopressors or mechanical support or on both. But we have to get to some basic simplicity and on that to build up the granularity. So again, these are things to discussion, but if it's going to be too complicated, it's not going to be useful for clinical trials. And that's the concern. And I think around that, we try to put something which would be more simplified, but it does have all the other categories that being collected and available for later analysis.
Yeah, let's see if any of our FDA participants, I've seen Bram and Meyer and Ileana, and there may be others from the agency on the call. Any perspective from FDA?
Mayor, why don't you begin?
So this has been very helpful. And I would say one thing, looking at the sky, when it says may include any, it doesn't actually say should include at least one. And I think looking at it, it means that somebody can become class stage C purely on the basis of operator decision. And not all of the operators of the registries are here today and not necessarily have the same. I know some interventionists whose first reaction to hypertension in an acute MI setting is going to be to start therapy, an intervention. And so the question is, to what extent does one require for stage C anything beyond the decision to intervene, but also some objective criteria? So the extent is it may include, or does one actually require that one of the above be, one of them be documented?
Hey, Sean, do you want to go back to the prior slide with the definition? Does that, does that sort of, address some of Dr. Shinar's comments? And if so, do we want this definition and the following slide with the staging to really line up more, right? Because here, we do require at least one hypoperfusion criteria. For example, we use that language, require at least, one or greater of the following. So, how do we reconcile Dr. Shinar's comments and then what is on this slide versus the following slide? Any thoughts about that?
Well, I think it comes down to whether we're talking about a trial or a registry. So if there is some discrepancies, but also some overlap. So if we're going to enroll someone with cardiogenic shock, and they would have to have hypoperfusion, so it would be at least Sky stage C. However, this opens the possibility to registries that are going to catch the broader spectrum, meaning stage A or B, and they would not be shock according to hyperperfusion criteria. So this is meant to be all encompassing and reflect a broad range of patients.
And then on the next slide, maybe you can go back ahead, Sean. And for the group, should we require some, some sort of minimum, documentation of, at least one of these signs or symptoms or clinical findings, laboratory data that support, the staging, the acuity staging of these patients?
Well, Bill, wouldn't you agree that that's the way to go? Because you want the registries to be informative, even though they're going to catch a broader patient net. I think one of the problems right now with the registries is we can't really clearly define the phenotypes that are in them.
Yeah, I agree. Yeah, but let's hear from, there's plenty of room for other opinions. So let's hear from the rest of the group, but I think you're right, Graham.
Yeah, I would agree, both from, the perspective of the AHA registry that's upcoming, and then also an ongoing registry we have that we view it as a two-step. One, you have to meet the definition of shock that's on the previous slide that has clear evidence of hypoperfusion. And then once you've met that definition, you apply additional staging to help classify the severity. And I think that to Ron's point earlier, you can really support that classification by capturing the individual critical variables to support it. So if you capture lactate and you capture urine output, for example, and you capture elements of the physical exam or the evaluation, then you have within your database clear data to help you codify. What's a little bit harder, at least in registries from the current version of the Sky stages, is that there are some elements that really are just based on a clinical assessment of trajectory that is not captured in most data sets, and therefore very difficult to apply in its current form.
Yeah, Dave, would you agree though that the may include any of might be better stated for
you
the
need at
SHARC
least
purposes
one.
as should include at least one of the following?
I agree. I think you need at least one, although you might have a sign of hypoperfusion in biochemical markers without necessarily having one on the exam. But I would agree you would have to have one from the third or one from the fourth column there to indicate that there's hypoperfusion.
Other comments?
So one thing, Bill, that I'll throw out again is from the practical side, the ability to apply definitions. If we're looking in a research environment for sites who use shock teams, that the shock team can determine which phenotype is which with the tools that they have when they see a patient in the ER, or even as a patient's being transferred from another center. I think just keeping the practical part of this in mind is very key. The other part of this to recognize, and this is separate from defining these, which this is this group's task, but in the application, obviously, with little bits, sometimes very little bits of time, patients may change. That is probably one of the most challenging methodologic aspects of understanding who shock patients are, because they may not be the same 15 minutes later. So again, the practical side of repeatedly applying criteria is another aspect, just to keep in mind, more on the methodology side of, in a trial, are you getting better or worse, or before you can get support to the patient, have they changed? These are some of the challenges, and the more practical, but also the more consistent we are in these stages and their definitions, the more useful they'll be to help us really create evidence in the space.
Now I see that Alex Truesdell has commented that there'll be more detail, and I guess this is in regard to Sky will address responses to therapy as well. And you know, I know you can't say anything about what's embargoed, but I think that comment in and of itself is important for us to consider as well. You know, certainly in describing a definition of a heart failure event, heart failure hospitalization, or some other worsening heart failure event, you know, this concept of also requiring some information on response to therapy has been important as well. So, you know, does the group think that that's important in the shock setting as well? Is it, in some way informative, confirmatory, add to the definition, or is it different in shock than in heart failure?
Well, maybe I'll start. I don't know that I would see it. I certainly may be supportive. I don't know that it's necessarily a requirement. I mean, unfortunately, we all take care of all too many patients with shock who don't respond to any of our therapies and have a quick exit. And that does not mean that it wasn't cardiogenic shock.
Yeah, no, I get that. And, you know, what Alex says here is that responses in parentheses, positive or negative, again, maybe there are some complexities in trying to define that. It'll be very interesting, Alex, of course, to see what Sky says about that. And maybe after that's out, the working group can take that into consideration.
It's Graham Nickel. May I comment on the issue of time?
Please, yes.
So I understand that my perspective is as an emergency physician and clinical trialist, not as a cardiologist. And we'll talk more about these issues in the exception from informed consent part of today. But time is a challenge here, because if one accepts the view that the therapies you're considering need to be applied quickly, you've got a limited time to identify and enroll patients. Using a hemodynamic criterion would obviously complicate that. And using a time-based response to therapy criterion may complicate that too. Both might reduce the effect of the intervention. As well, I think one might expect that FDA might take the position that if your inclusion criteria includes time or response to therapy, that time may, or the use of that time may allow you to obtain informed consent.
Yeah, again, I think that if you look at those criteria from A to E and you snap them at the time of enrollment, so think about the clinical trial scenario, because you can have a clinical trial just for E, or you can have a clinical trial just for A and B. I think the issue is to define the patient at its status at the time of entry into the study. 5 minutes after that, you can basically apply the therapy that you're studying, whether it's going to be MCS, whether it's going to be a drug, whether it's going to be early vent. I mean, whatever you want to apply, you apply at the time that you enter the patient into the study. Now, it could be that the patient will deteriorate over time. That's a separate story. But I'm thinking about this for the purpose of clinical trials only. And I don't want to dictate what would be the therapy, because that's probably going to be the study question. So if you have a study question, you have to leave all the options open and just describe the entry of the patient by the inclusion and exclusion. If I do, for example, a patient just for A and B and C, and I say, I don't look at D and E because I think nothing is going to help them anymore, so it's too late, then that should be the importance of enrolling the patient at that stage. Or if you take the other way around and you take just D and E, these are the patients that are going to be in the inclusion exclusion criteria. So for that purpose, I think we have to simplify and be very descriptive. Who are the patients that entering? Maybe 5 minutes later, they would be in a different class. But at that time, we enter them, that was applied to their status.
Yeah, I think you're right, Ron and Graham. I think your comments, are really helpful. If we're focused on entry criteria, certainly response to therapy doesn't seem to fit. Maybe it's better off being thought of subsequently in sort of adjudicating, events later. But I think you're right. I think that's really an important issue you raised. Both of you raised that. At the time of presentation or entry into the registry, we may have no idea what the response to therapy is, but it may be something that we want to have, measure, document later, down the road, because at some point in our clinical trials, there's likely to be a clinical events committee or events adjudication committee that's going to review these records and try to either endorse or refute whatever diagnosis the investigator makes here.
Yeah, and I think, Bill, it will, along the lines that Ron brought up, it's going to change. So you probably need in the CRF to have the stage of shock at the time of presentation, and then, almost every 24 hours updating the stage of shock, because the patient could come in. Obviously, every patient who hits the ER in the hospital is not yet on pressors unless they got in the ambulance, and not on an MCS yet. So by definition here, every patient at the time of enrollment, you could say, is a SCI class B, but within 15 minutes or 30 minutes, they're in the cath lab or somewhere, and they're getting pressors and they're getting MCS support. So they actually are a C right away. So you have to, I think, be pretty clear at what time point the patient is classified on admission, not within 5 minutes of rolling in the door, but maybe within about an hour. So you could see whether they're actually going to need pressors and MCS support, which would put them in a C. And then I think the deterioration, so it just says deteriorating, to go from C to D, there should be a more clear definition of deterioration, either aortic, either arterial pressure, hemodynamics, cardiac output, rising lactate, worsening metabolic tests, but some more specific. And that maybe that's what's going to come out at SCI when we see the more detailed SCI classifications will help define what deterioration really means. But I think we've got to be pretty specific about that, or you'll have a lot of subjectivity in that across different studies.
So good afternoon, everybody. This is Tim. And sorry, I was a little bit late, but I had a case that I had to finish. Just to that point, Chuck, we will be presenting the update in the classification at TCT next weekend in a special session, and have the manuscript that's approved by like 6 or 7 societies that we hope will be online at the same time in JAC as well, we believe. And I think our goal is to do exactly that. There's been now 12 trials that have validated it, one prospectively, the rest retrospectively. And we use data from that as well as from the registries to provide more granularity. And a second thing I'll say about it's a great idea to do at baseline. So at arrival and have a shock stage, but then like every 24 hours, that's a terrific thing, because it will be able to look, the one prospective study David Barron did, the actually change in the shock stage was of course very predictive. So if you're getting better, obviously it's self-evident, but if you're getting better, it's good. If you're getting worse, it's bad. But I think that would be really helpful to assess therapies as you're going on, and very simple to do, right?
Yeah, and remember that this, and I do want Ileana's had her hand up. I want her to comment next, but remember that this SHARC effort is being done, alongside a lean CRF effort as well, and maybe Mark Samsky wants to comment on that. But I think some of these issues that you raise about repeating the assessment, at time intervals, really are incorporated into the thinking around the lean CRF. Ileana?
Yeah, so I may burst your lean CRF bubble here because this reminds me, first of all, it reminds me a lot of what we did with Intermax, trying to make the definitions understandable to the clinician at the bedside who's actually taking care of the patient. But in addition, I also think of the operating room. And this reminds me of when the patient's put under anesthesia, how the anesthesiologists are capturing, blood pressure, heart rate, medications, whatever they're giving. So we may want to think in the CRF, and I'm thinking the coordinators are going to have to get these data, put down in a CRF. If we do, like in the anesthesia, like a little table that can be tracked, especially for the first 24 hours. And it would be very easy to see trends in blood pressure, trends in heart rate, and trends in responses. So just as thinking of actually putting it on paper.
Okay, thank you.
Bill?
Yeah.
This is Mitch, because again, Ileana is talking about something that I think is critical to this field. I think as a first pass for SHARC, this may fall into what I think in every section we're going to discuss today may have to be aspirational definitions. The whole notion of trajectory, turning points from better getting worse, or from worse getting better for escalation, whatever. That these are things we really need to capture, but we may not come up with the final definition on the first swing of the bat when there's so much else that's just a rat's nest to reach consensus on. But I think capturing them in the aspirational category helps us also understand where we need to go, and whether that's methodologically or definition wise or both, because a definition on trajectory is useless if the site staff actually won't capture the data that it takes to define the trajectory. So that's the balance act that we're in. But I think these are critical concepts and constructs that we want to keep an aspirational bucket, probably for in every one of our sections through the day, because they're critical.
I'll just chime in and say that we were very intentional about designing the CRF to ascertain the sky shock stage at the time of arrival, and then to allow for investigators to essentially assess it as frequently as desired. So Dave and Alistair and Bill, everyone who's part of that meeting, we were very, very intentional about that.
Okay, any other comments on session one? We still have 5 minutes on the agenda, or we can move on to session two. And I do think that there is, there's a little bit of overlap. So this discussion may continue into session two's discussion. Anything else?
Bill, it's Alex. Can I try? Sorry, I know it's noisy in the train, but
please, no, go ahead.
Two quick comments. One, don't forget that half of the cardiogenic shock are advanced heart failure, then it's difficult to know when is the start. I think with acute myocardial infarction, cardiac arrest, we know when is the start. Heart failure, we don't necessarily know. Then I would say, let's use a SKY definition when we can, when we need, but maybe not necessarily at baseline. I heard many times baseline or at admission, because many of those patients can deteriorate later. And my second comment is on stratification and ECRF. We know that one of the major factors is more comorbidities and age, and we should not miss that one, because the stage it's something.
Yes, we lost him.
Yeah, okay.
Train in a tunnel.
Okay, well, if yeah, there he is.
Age and comorbidities are very important.
Okay, thanks, Alex. And it's a good segue now into the next session, which is classifying populations to be studied in cardiogenic shock research. and Patrick Lawler, Alex Mabaza, and Dave Morrow sort of led this group as well. And before I turn it over to you, I just want to say, Dave Morrow, I think you get the award for being the best dressed person on the Zoom today. So good to see you. All right, who's going to start off from the group?
I'll start it off, and I just was trying to step it up for Mitch and the importance of SHARC here. No, I do want to start from the get-go and just recognize all the hard work that everyone has been doing, as Mitch said from the beginning, and everything I'm showing is the collective input from Patrick and Alex, and also all of those who've been on the preparation calls for this meeting that have given us valuable feedback. And so as Sean already outlined, there really are two key components to identifying the populations in any clinical cohort for a trial or a registry. In addition to meeting some basic definition to get in, there are a variety of forms of cardiogenic shock based on underlying cause, their timing, as we just heard from Alex, whether post-cardiotomy shock, as Ileana even was hinting at as well, thinking about the OR. And then there are a number of different modifiers, and Tim has underscored many times before the importance of cardiac arrest in this patient population. And then there's the classification of severity. And as Sean said, our group's task in section 2 was to focus on this upper classification and phenotyping of shock patients. And so we're going to outline a draft classification of populations for you to seek your feedback. I'm going to go through each element of the definition, and then we'll have a number of discussion points that we come to at the end. And so in coming up with this classification, we were considering the underlying cause, whether it's acute MI, chronic heart failure, some other primary cardiac cause like critical aortic stenosis, for example. Timing, we're going to talk about more. And then there are a number of other considerations because we haven't mentioned yet, but mixed shock is a common case in our cardiac intensive care units now, where patients develop superimposed vasoplegia on top of cardiogenic shock. Whether it's LV, RV, or BIV, whether there's transient shock as well is also a phenomenon that we see where things get quickly better, whether there was some transient insult, might have been ischemia that was relieved by Mitch in the cath lab. And then whether there was cardiac arrest along the way, or even at its most extreme, whether a patient presented with eCPR being necessary. And so we propose to divide cardiogenic shock into 4 basic categories: AMI cardiogenic shock, heart failure related cardiogenic shock, which incorporates both those with chronic underlying heart failure who present with acute decompensation that results in shock, even patients who may be chronically in shock and hypoperfused at home. And then those patients who present with de novo cardiogenic shock from a myocardial cause, such as myocarditis. Post-cardiotomy shock is a group unto itself, and then secondary cardiogenic shock, which I'll flesh out a bit more in the coming slides. And one of the discussion points for us to come back to is that there are other terms for some of these groups that have been used in the field, and we can think about whether those should be moved forward or whether what we're proposing here ultimately makes more sense. And so now if we dig a little bit more deeply, we can take each of those 4 categories, and the top one is maybe easiest, the most deeply studied and familiar to us, and that's cardiogenic shock in the setting of acute MI, whether it is STEMI or non-STEMI, where it is the acute ischemia that is the primary driver of the event. This isn't a small non-STEMI in a chronic heart failure patient who has a little troponin. This is the patient where ischemia is really driving the shock presentation. Then heart failure related cardiogenic shock, as we talked about here, this is where primary ventricular failure in the absence of AMI is what's driving the shock. The two categories are de novo and acute on chronic, but there are a number of different specific etiologies which aren't necessarily required to get into any clinical trial, but you want to make sure that you have captured. Or to Ron's point, you might want to just do a trial of cardiogenic shock from myocarditis, and that's perfectly fine. That fits into this framework. And so we'll talk about some of the additional modifiers as well, and how that gets incorporated. Each of these we've mentioned at least transiently already. Secondary shock, cardiogenic shock is a bit of a grab bag, right? We have patients who have, this is all unifying here, is that it's a primary non-myocardial cause. Ultimately, there may be LV or RV dysfunction, but still the primary cause is tamponade, or the primary cause is critical aortic stenosis or new papillary muscle rupture outside the setting of an MI. And those are then obviously subclassified by a specific cause. Arrhythmias end up being a little bit challenging here because they may be secondary to shock rather than the driver of shock. But this is aimed to capture the patient who comes in with new atrial fibrillation and at a heart rate of 160, they're hypotensive and malperfused. It's driven by the AF as the primary problem, not any preceding myocardial dysfunction or structural disease. And then lastly, the post-cardiotomy cardiogenic shock, where obviously we would also classify by the surgery type, at least within the CRF. And so now we're going to walk through each of those definitions with a little bit more granularity to say what it is and what it isn't, and raise some discussion points that we're going to come back to in about 5 minutes. So this is acute myocardial infarction, cardiogenic shock. Obviously, acute onset cardiogenic shock due to acute myocardial infarction. We already said STEMI or non-STEMI. Acute myocardial ischemia, ischemic injury, or mechanical complications are the cause of shock. And this is important. We propose to include mechanical complications here rather than putting that into another category. And then it also, we propose to include cardiogenic shock where you have acute arrhythmias, acute bradyarrhythmia, VF, VT in the cath lab when they first arrive, or post-cardiac arrest in the setting of MI, we propose to include in this category. But this is a discussion point because you might consider peeling some of those off into other categories if this group thought that was the best thing to do. Certainly the post-arrest group is a little bit complicated because their shock may be ongoing for reasons other than the initial MI itself. Next group is the heart failure related cardiogenic shock group, and that is the group of patients with primary myocardial dysfunction. It may be RV, LV, or both. Non-ischemic or the sequelae of ischemic heart disease. We do point out here what it isn't. It isn't due to primary non-myocardial cause like critical aortic stenosis, acute pulmonary embolism, or incessant AFib. And it's also, we pull out the post-cardiotomy into its own category. But there are a few groups of patients that are a little bit more complicated that we should talk about. What about patients with RV failure due to chronic pulmonary hypertension? Where do we put those people? Are those best under secondary, or do we consider it secondary to the pulmonary hypertension? Or do we really want to focus on the RV dysfunction and keep them into this group? Because that's a kind of a mixed population. And then patients with hypertrophic cardiomyopathy that may have outflow obstruction, is that secondary or is that related to their myocardial disease, and do you want to keep it here? Then within that group, there's the acute on chronic, which is acute decompensation of chronic heart failure. And then there's the de novo group, which is due to new onset, known or suspected acute myocardial dysfunction. And specific etiologies we most likely would want to capture, but not require, again, necessarily to meet the classification. Myocarditis, Takotsubo, amyloid, hypertrophic peripartum septic cardiomyopathy would all fall into this group. Discussion points. What about patients of unknown chronicity? Do we peel them out into a separate category, which with a name that this erudite group will come up with? Or do we force people to put them into one of those two other categories as their best guess? And then discussion point as well, is there anything else you guys see that we should put on that list? It's not intended to be exhaustive for key etiologies, but are there any that you think have a discrete natural history or unique treatment and therefore really should be spelled out? Then for secondary cardiogenic shock, these are all primary non-myocardial cause, valvular disease, pericardial disease, pulmonary embolism, incessant arrhythmia. Doesn't include those two groups that we've already identified. And then we'll come and talk about what you think about hypertrophs and pulmonary hypertension. And so we can pull that all back together and really use this single slide as a branch point for discussion. These are the 4 groups, and then these are the 6 principal areas for discussion. And of course, anything else that people want to raise. So I'll just leave that slide up for a bit and let you guys start the discussion.
Yeah, terrific, Dave. Really a very clear and well articulated proposal here. So let's go ahead and open it up for discussion. I'll just start off by asking if, either of the co-leaders of the group want to make any additional comment before we open it up to the rest of the group. Patrick or Alex, anything you want to add on top of what David has already presented?
Terrific, Dave. Nothing to add from my end.
I can confirm that Dave is wearing a French suit.
Outstanding. Well,
Dave, I think it's Italian, but that's okay. It's Central Europe.
Dave, to your point, I think we do have to think about normotensive shock.
Yep. Yeah, no, that's fair. I think that those patients can easily fit within this classification, but that definitely does reflect back to Sean's point earlier in the primary definition, whether we include it.
Bill, if I may, this is Illy.
Yeah.
In that, Dave, this is fantastic because you really have sat down and sort of peeled the onion as we see these patients where sometimes we're back and forth in the diagnosis. One diagnosis that I'd like to add to your previous slide is the post-doxorubicin patient who may have been chronic for a while and then something tips them over and they show up acutely, and their management is really hard because you don't know what to give them, and they get either very dry or very wet very quickly. So I think that I'm not sure if anybody would agree, but I think these are very difficult patients that kind of really stand out.
Yeah,
so, the inner person is trying to put in a device and it's not working. And it's not working.
Yeah, maybe I'll just say I think that group, but tell me if people should react to whether this makes sense. Under our current proposal, that patient would fall under acute on chronic within the heart failure related cardiogenic shock, with then a specific etiology of doxorubin related, anthracycline related cardiomyopathy. If you guys think though there's more granularity that we should give to peel those out even further, we definitely can consider that.
Yeah, I'd love to hear what others think about.
Well, I think it's a great suggestion, Ileana, and I don't recall, Dave, if we had sort of a a category of toxic cardiomyopathies, right? I mean, this is a drug toxicity. There are other drugs other than anthracyclines that might do this, and then of course there are a lot of let's call them recreational drugs that that might be associated with either acute or acute on chronic heart failure, cardiogenic shock. So I think Eliana brings up a really great point. I see a lot of these patients like she does. And actually in this doxorubicin population, this is not an uncommon scenario. So thanks, Eliana, for bringing that up. And I would agree. I think that should be added.
Yeah, we'll make sure that it's in the key etiologies under heart failure, cardiogenic shock.
Yeah, David, I'm sitting here thinking because I think a great exercise, as you guys have done, and I've heard you walk through, is just walking through specific patient presentations. And do we have a category that clearly welcomes them and captures them? The only thing I'm sitting here thinking with Ileana's comment is whether secondary cardiogenic shock, sort of, heart failure, cardiogenic shock is kind of a secondary to the etiologies of heart failure, and whether there's something distinctive we can make about secondary, I don't want this to get too cumbersome, but secondary non-heart failure or,
Yeah, Mitch, no, that's a really good point. I think that what we proposed, and I'll just spell it out to be more clear, because we'll have to make this really clear in the document, is that there are sort of two frameworks for secondary. The cardiomyopathy might be due to secondary to doxorubicin, or it could be secondary to sepsis, or could be even secondary to over beta blockade, right? Secondary to other or drug use. There may be a number of causes. If the primary cause is myocardial dysfunction as the main driver, they would fall under the heart failure cardiogenic shock. The secondary we're using here, at least the way we had framed it for a start in this draft, is the secondary is secondary to a non-myocardial principal cause. So pericardial disease, valvular disease is the primary driver, or incessant arrhythmia. So a toxic metabolic or toxic cardiomyopathy would fall under heart failure cardiogenic shock. Critical AS, torrential MR, those folks would fall into secondary CS. But that group is kind of a grab bag and may not be the one that people focus on to study, but we need to be able to describe them at least in our registries.
But Dave, one of the issues that maybe needs to pay attention, whether you identify a causality or a diagnosis, or you're just describing a physiology. AMI, it's a very defined disease. Heart failure also could be, but there are some states, whether it's the left ventricular failure, mixed, right. So there may be a mixture of diagnosis versus, especially when it comes to the secondary, versus the state of what is the failure. Is the failure is left, right, both of them, or any other descriptions? So that's where I'm struggling right now to differentiate the
that also
causality.
is also naturally a really important point. And I guess our proposal again, but this is for us to discuss right now, is one approach would be to create branches off each of these and get out far into the tree with a lot of more leaves. And that definitely is one approach. The other is to keep the categories, but then be able to attach modifiers that you would have in your database. But of course, if your population for your trial, you wanted to study right ventricular shock only or biventricular only, for maybe you wanted to study biventricular device therapies, then obviously you could pick that group and they would still fit into this. But we were thinking to add modifiers to these rather than branches, but we should hear from the group what they think is going to be easiest for people.
For example, Dr. Sigurella suggested illicit drugs. I mean, you can suggest top COVID-related cardiogenic shock, pulmonary embolism cardiogenic shock. So this comes like to the diagnosis or the causality versus the state of the. So I think we have to maybe more elucidate which one are we describing? Maybe both. Sometimes you don't have a diagnosis, but you do have the physiology that you have to take care of. So I think it's easier to define the physiology. The causality would be, again, subject. Think about the context of the trial. So if the trial is going to be just on patients who were on illicit drugs or COVID related or septic related, or that's one thing. If it's just taking care of any right ventricular failure that led to a shock, no matter what's the causality, because what we are testing here, I mean, you can say, okay, one is going to be natural history of the disease. The second thing, intervention. These are the two things that we can look into, but we will have to differentiate it by the disease or by the physiology.
So Ron, maybe what we could do, if you and Bill are okay, is pull the FDA into this conversation, because I do think from an ARC perspective, what I have liked about the way this group has approached these designations from the get-go is these, to me, do kind of have suitable boundaries for populations of use that would be definable enough to understand device behavior within them, and both good and bad behavior. So I don't know, Bram, Andy, I'm just scanning down. We've got a great FDA group on the line. Anybody from FDA help us with, are these understanding, we got a lot of granular ways to enter these 4 buckets. Do these 4 buckets at least help us from understanding populations in whom we use devices?
And Mitch,
Yes,
I want to say we
Mitch.
see Tim, so definitely Tim has been really patiently waiting. We will get to you, Tim, after Bram.
From an FDA perspective, we'd like to keep it reasonably simple. I think these are good initial buckets with Dave's comment that we can always add modifiers. I don't think we need a full tree drawn at this time.
Yes,
Sorry, Tim, I didn't mean to delay your comments.
Tim is in Henry. Yeah, so first of all, I think it's excellent. And it is complex, but first of all, the cardiac arrest. Cardiac arrest, I think, is well fit for modifier because we know that it makes it markedly increases mortality in any one of these. So if you just take STEMI and non-STEMI with the cardiac arrest and the new shock classification, we've clarified the modifier, and that is cardiac arrest with unknown neurologic recovery. So getting shocked once and being normal neurologic doesn't get you there. But I think the biggest issue is because mortality becomes about half the mortality in those patients are because of brain death. So it's quite different. And so I think the modifier for cardiac arrest is probably important and could be put in any of these. And the second issue is in terms of that I thought, having someone who comes at it from a STEMI standpoint, we have 2 important unique subsets in STEMI and that one is with spontaneous coronary dissection, and which was not mentioned but should be, and that could be just a clarification because it's actually cardiogenic shock is actually more common in SCAD, and then the second one is Takotsubo's, because I think of Takotsubo's as myocardial ischemia. Because you have ST elevation, you have ischemic symptoms, and you have elevated enzymes. And so they're in our STEMI database. So that it's worth discussing that. And I also would argue about one of the things I think differentiates a myocardial ischemia is that my own personal feelings are that pressors are worse for that bucket. And that fits also with Takotsubo and SCAD. So anyway, just those, but really excellent, you guys. I think it's a terrific format to start on.
Tim, where would you put the SCAD? Would you put that as sort of a modifier under AMI-CS
Yeah,
you know,
I would. I'd put it in AMI,
Yeah.
but I'd put it with the modifier because it is a distinctly different population.
Yep.
But it acts like myocardial ischemia. And I believe the same for Takotsubo.
Yeah, what do people think about the Takotsubo, which right now stress cardiomyopathy would be under, usually under de novo, heart failure, cardiogenic shock.
Yeah, I'll make a comment, and I'd love to hear from some of the other heart failure oriented folks on the call, Ileana, Mayer, and others. I think the sort of pathogenesis of Takatsubos is is a bit complex, and while there may be an ischemic component, there's likely an inflammatory component. There's also likely a neurohormonal component, with demonstration of very high catecholamine levels in these patients. And from a heart failure specialist view, I see this more as a stress-related, toxic cardiomyopathy, acute cardiomyopathy, than really the equivalent of an ischemic event. So I would argue in favor of leaving this with the de novo heart failure group rather than moving it over to the AMI-CS group. But again, open to consensus from this group. Ileana, Mayer, anyone else have comments?
I agree with you, Bill. I would not put this on the ischemic group. I think that fits, and the patients in general recover fairly quickly within a few short days, and it's a dramatic improvement. If it were ischemic, it wouldn't be so dramatic.
Just as an alternative, I will point, they do have elevated enzymes. And another key, I think that the like inotropes work well for that heart failure cardiogenic shock group, but I think most of us try to avoid inotropes in stress cardiomyopathy. So that's why personally, we count them when they come in. They come in with ST elevation, elevated enzyme symptoms. So we keep them in the STEMI database already. But listen, this is why it's fun to have other people's ideas, because it's not like it's going to be definitive for sure.
Yeah, but think about the clinical trial that you're going to do. If you're going to do a clinical trial on Takotsubo, you're going to, hey, I'm doing for Takotsubo patients. You're not going to put Takotsubo because they have heart failure with all the other bags, because then they'll say, oh, maybe Takotsubo should be an exclusion criteria, because even we don't know the mechanism of that. So I think the thinking of the group should be really in the context of clinical trials. That's what we really need to make sure that we uniform. So every time that anything like that pop up, like for example, we are actually looking now whether there is a microvascular disease that's related to Takotsubo. I mean, there's so many etiologies, and we're just going to get to the more complex. We heard from the FDA, they want something simple, and we want something simple. So
yeah, and that's a good point, Ron. I think that would be the key about some of these unusual ones, is that they would actually be exclusions for a clinical trial. And, I would agree with that totally. And Takotsubo should have its own separate clinical trial. You can recognize it, you know what it is. It should be looked at as its own group.
Yeah, and I guess the one thing I'd say is that definitely I think SHARC is aimed principally at creating definitions for investigators for clinical trials. But I think as Mitch spent all day, along with many on this call, working toward, I think part of our future is using the infrastructure of registries to engage clinical trials. And so I think our second vantage point is also registries. And from a registry standpoint, you also need to think about, are the people who are going to get captured in this registry, can I put them somewhere? Is there somewhere logical to name them? So I think it's that vantage point that we're thinking about some of these smaller groups, is at least you know where to put them, so that if you're comparing one registry to another, they're sort of in the same bin, without necessarily telling people that they need to enroll patients with RV failure due to pulmonary hypertension in their heart failure trial. And I guess we had some other specific etiologies that we'll add. Ileana, thank you very much for that. That's a great point. Maybe I will ask just about the pulmonary hypertension and the hypertrophs and outflow obstruction. Do those go somewhere else? Do those go in the secondary, or do they fit in the heart failure related? Where would all our advanced heart failure folks put them? I see the grimace, Bill, because I agree, it's not so easy. I don't know.
Eliana, you're in mute.
Yeah, no, I think these are a couple of tough ones, and of course that's why you've pointed them out. And I'd love to hear from some of the other, heart failure focused as well as the non-heart failure focused, folks, folks on the call. These, I think these are, I don't know, almost unique enough that maybe they go into, a secondary category. I think I would lean toward now, but I could easily be convinced that, they could go into the heart failure category. But, these are two categories that sort of stand out, more than they, sort of line up with the other heart failure etiologies, I think. Ileana, what do you think?
No, I agree with you. I think this is a smaller bucket. It can be teased out later because there are going to be less patients with those diagnoses necessarily than the common heart failure that gets sicker and sicker and then boom, crashes. So I'm with you on that, Bill.
I know that sounds pretty reasonable. Patrick or Alex, do you guys have thoughts or a leaning?
That sounds very reasonable to me too.
No, I think I agree. Most of the pulmonary hypertension are secondary to left ventricular dysfunction. Then I think it makes sense to put them in heart failure.
All right, yeah, and I think actually that is sort of the mindset we got in on the universal definition of MI, which I know is also a favorite topic, but was that, it's putting more things under type 2 MI and secondary made more sense, even though it created a heterogeneous group. We wanted to keep the purity of type 1. And I think your point, Bill, about maintaining the purity to some extent of heart failure CS, so we all know what that means. Probably that makes good sense.
Good. Dave, any other specific points that you and the leads for this group would like to get input on?
I think the other details are things that we can talk about once we start writing, but we'd welcome if there's any other major thought that went through folks' heads as they saw this that they want to mention to us, please.
Excellent. I think we should move to the next session.
Go ahead, you take it, Ron.
Okay, so far we are on time. The next session is also very important. It's going to be defining scenarios for EFIC. And the leaders of that were Catherine Wentz, Neil Deckard, and Graham Nicol. I don't know who's going to take the presentation, but you have 10 minutes presentation and 30 minutes discussion. Neil, I assume it's you.
I think Graham's actually we're gonna tag team. Graham's gonna start.
So Graham, unmute yourself.
You would think I would be able to use Zoom. Can you hear me now?
We do, yeah.
Okay. So this is a combined effort. Catherine Wentz's name is on the program, but she did ask us, and she has contributed to this, but she did ask us to make clear that the following material does not represent the official view of FDA or its staff. As well, I wish to disclose that I'm a consultant to Abiomed and Zoll Circulation, who both have products relevant to this discussion. So the format is I will gently remind you of requirements for conduct of an exception from informed consent for emergency research study. Neil will present our thoughts on a reasonable path forward, and then Catherine and Mike Weisfeld from Hopkins, who also contributed to these discussions, will make some brief comments before we open the discussion. So this slide summarizes the a priori requirements which must be met before a study can proceed under exception from informed consent for emergency research. Patients must have or patients who aren't intended to be enrolled must have a life-threatening condition that necessitates urgent intervention, and the available treatments are unproven or unsatisfactory. They cannot provide informed consent because of their condition, and a legally authorized representative is unavailable or unable to provide consent. The study itself must involve an investigational product or strategy that must be applied before informed consent can be obtained from the patient or LAR. And note that there are, in essence, two virtually identical sets of regulations, one which governs investigational products under the purview of FDA, and the other governs strategies or research that's federally funded under OHRP. The intervention must offer the prospect of direct benefit to the patient, but that does not have to include a mortality benefit. Morbidity benefits are also allowed. The risks have to be reasonable in relation to the condition and standard care, and the research cannot be practically carried out without exception, which I think will be a discussion point for Neil's part of the program. And there's no reasonable way to identify prospectively patients likely to become eligible. For an FDA regulated study, an IDE or IND has to be in effect. The research involves human subjects who cannot provide informed consent. The intervention has to be administered before the consent. The sponsor has to have written permission from FDA before initiating enrollment. An independent data monitoring committee exists, and the relevant IRB has to have documented that these conditions are met. We talked a little bit about timing earlier. The therapeutic window is the time period after the onset of event within which the investigational product must be used in order to have its potential clinical effect. And so this particularly, I think, will guide you as you think about trials as to which stage of cardiogenic shock an exception from informed consent trial might apply to. It is expected that the protocol would define the duration of the therapeutic window based on empiric data, and the patients likely, the proportion of patients likely unable to provide informed consent within the therapeutic window would also be based on empiric data. The protocol would also need to specify who can serve as a LAR, legally authorized representative, and procedures for contacting them, and how much time within the therapeutic window should be consumed by this. It's recognized that a therapeutic window for emergency research may be very brief or even non-existent. For example, the multiple cardiac arrest trials that I've been involved in over the last 15 years have virtually no therapeutic window. It's also recognized, however, that any declination to participate within the therapeutic window, such as a family member at the bedside who says, "No, I don't want you to enroll the patient," must be respected. There are obviously potential barriers to consent in cardiogenic shock trials relevant to the practicability of obtaining consent within the therapeutic window. These patients, if they're type C, D, or E, have organ hypoperfusion. They may or may not have legally authorized representatives available. The capacity of either the patient or the LAR to consent may be limited due to multiple challenges in the heat of the moment, including time limitations of lack of familiarity with research, and the brief time period or therapeutic window in which the intervention must be applied. We believe that these challenges are likely to be more significant than in most STEMI trials. There is limited empiric data which suggests that there are potentially some consent-related issues in acute cardiac trials. Obtaining consent from patients with STEMI to participate in research can consume the therapeutic window. about 40% of family members available on scene of cardiac arrest when surveyed retrospectively would have been unable to provide informed consent. About 60% of cardiologists report that patients only sometimes, almost never, or never know what they're accepting or refusing in the course of clinical care. The majority of patients enrolled in a STEMI trial did not remember being asked about the trial 1.5 days later. And the majority of patients with STEMI enrolled in a fibrinolytic trial did not read the written information provided. So these are 2 prior trials. This is obviously a selection of the available trials that have been completed. On the left, you have the CRISP AMI trial, which was really informed consent or used informed consent before enrollment of patients with STEMI at risk of cardiogenic shock. So these would have been type B or stage B patients, to use your vernacular. EFIC clearly would not apply to those patients. And on the right, we have the IMPRESS trial from the Netherlands, where they used waived informed consent, which is not what we are proposing, because 94% of enrolled had cardiac arrest before they were randomized. Note the large difference in mortality. And I think this group is most interested in type C or D patients who would be in the middle and have an intermediate mortality, some of whom might be able to consent, some of whom may not be able to consent. So this is my last slide before Neil takes over. And Neil, I can just click the slides forward. This is the potential approach to enrollment under EFIC. This was presented to the FDA's EFIC committee. They did not opine on it because we were deliberately device agnostic. And they wanted to consider this approach in the context of a specific trial protocol, with the exception of Catherine, who will offer her own opinion. I think, and I'm not trying to pick on Catherine, I appreciate she can't offer an official opinion. Neil and Mike and I believe this is a reasonable path forward, but I think it's important to understand that this has not been approved by FDA. So patients with acute STEMI and cardiogenic shock who are otherwise eligible for enrollment in a trial, one would consider, do they have altered mental status secondary to the medical condition? And is their legally authorized representative unavailable? If yes, you could enroll them under exception from informed consent. You'd need to notify them of enrollment as soon as feasible afterwards and obtain consent for ongoing participation. If no, we believe a reasonable approach would be to present a finite script to the oriented patient or available legally authorized representative to gauge whether they're able to engage in a conversation about what their condition is and whether they're willing to be enrolled in the trial. If they are, then you could enroll them if they obtained written informed consent. If they are not, then you would be able to enroll them if the patient or their LAR did not orally object to the enrollment after the script was read. I'm going to pass it on to Neil.
Thanks very much. And I'll move through the remainder quickly. So the first thing we want to highlight is that both of the categories on the right represent folks who are enrolled under EFIC, right? So that's both people who have no involvement and people who might be eligible for this brief opt-out or assent type process. Next slide. The second piece is that this is one of the difficult branch points that we'll talk about briefly, but this decision about sort of engagement and whether consent versus the opt-out assent process is one that's going to have to be made in real time. And that's a complexity about this, this type of trial that's really important. So we'll move to the next slide. The first group in that sort of top right section is not complicated in the sense that a patient who's profoundly altered and has no LAR available is not difficult to define. The real question here in operationalizing this, and it's relevant for both the approval under EFIC as well as how to conduct this trial, is that you need to estimate the proportion of patients that are going to fit in this group. And there are some surrogates, or not surrogates, not the right word, but data that could be helpful that include the number of people you expect to be post-arrest, the number of people typically with STEMI who are treated without signed consent. Those can give some indication of what you'd expect, and those would be important to provide. The second group, the bottom right group in the assent opt-out group, is complicated. These are conscious patients, or patients who are conscious or where an LAR is present, but consent is not feasible. It's much more difficult to define this group, and available evidence, as Graham described, suggests this is present within STEMI trials, but is probably substantially more likely to be present, I think, in the context of a sicker patient population with cardiogenic shock and very tight timelines. One of the most important pieces for this, again, both for operationalizing this framework under EFIC as well as for initial approval in the first place, is empiric data that would be more representative of patients with cardiogenic shock themselves. Next slide. One of the questions that I know is first forefront in this group's mind, and has been in ours as well, is how do you make that determination right at the bottom of that framework? How do you decide which people you go with a consent process and which people you go with an assent opt-out process? There's a couple of important things here. One is that there is no clear definition of how to make this determination within the regulations or guidance. The one piece that is clear in the guidance is that if you can get consent, you have to. We thought a lot about exploring options for formal tests, and that would be attractive if we had a couple of questions we could ask that we knew could establish capacity. But most formal tests of cognition were never intended to determine capacity for consent for research. They're designed for things like delirium or dementia, and that's not the nature of barriers we're dealing with here. Consent is a task-specific activity, and there are real risks of trying to employ low-value tests that exhaust a therapeutic window and don't provide insight as to whether the consent is appropriate. We settled after a lot of discussion, and I think it's very clear that this is going to rely heavily on clinical judgment as to whether the patient or LAR is able to proceed through that process to consent. This is routinely done in emergency care, but obviously research is a different context. There are some potential strategies that could be included that may include confirmation from an additional clinician, but it's very important that this be done in a very clearly protocolized manner, starting with the brief oral description and proceeding to consent if feasible, and providing an opportunity to object or opt out if not. So this has to be a sort of seamless, sort of stepped process. Next slide. And I think this has been done before, and that is important to recognize. There are brief, simple processes that can serve as some examples that can be used to avoid complexity and delay. But one of the things that's critical in this context is that documentation and monitoring will be essential. As I mentioned, it isn't novel. All EFIC studies are required by regulation to provide an opportunity to object when prospective consent from a patient or LAR isn't possible, but there's someone there that you can interact with. The issue is that this component of things has not been operationalized or discussed as widely as many of the other components of EFIC. And in this context with cardiogenic shock, this will be we expect this to be a larger portion of patients than might be in many other contexts. So important issues that we didn't really talk about but are critical to consider are issues with regard to regulatory differences in different countries. This is probably most substantive with regard to the ability to pull out data if people discontinue participation. The EFIC guidelines or EFIC regulations require community consultation and public disclosure activities. We're happy to talk more about that in the discussion section if that's helpful. The key point, I think, is that this is an unfamiliar activity to many investigators, but there's a lot of accumulated experience and it doesn't have to be a barrier. In fact, it may help to refine and ensure that the approach that's implemented is as patient-centered as possible. And obviously, there are important issues of diversity, equity, inclusion that have to be attended to. Next slide. So just to wrap this up, and I apologize, this is a long presentation, but I think the key pieces, number one, the regulations do define very specific requirements to qualify for EFIC. The key being that it's impracticable to conduct the study without EFIC because of an undue delay if you did it with consenting patients only, and because results that would be obtained if you only enrolled people who could provide consent would not provide data that would help to inform treatment across the entire population that the trial is intended to generalize to. It's reasonable, we think, as Graham articulated, again, this is something we think is reasonable, but absolutely not an approved formula, to seek to conduct a study in patients with cardiogenic shock under EFIC if the following conditions are met. So first, a large proportion of the intended study patients would be demonstrated to be unable to provide consent. Second, if the risk profile of individuals that are able to provide consent were different, such that you would cause a meaningful selection bias and compromise the science by only including individuals who could provide consent. Both of these components require evidence and are subject to interpretation by regulatory bodies, and we can't stress that point enough, but also think it's reasonable to move forward to try to provide that kind of evidence. The reasonable process from our perspective would look to engage patients in LARs and a brief explanation of the risks and benefits of participation, seek consent where possible, and give the opportunity to opt out where not. We do think it's important to recognize that formal capacity assessments that exist now are highly unlikely to be useful in this context, but protocolizing, documenting, and monitoring all aspects of this process are critical. And we'll close there. We have some supplementary examples that may be helpful in subsequent slides that we can distribute.
Mike, do you want to offer some brief comments, and then we can call on Catherine, and then we can have some discussion?
Yes, thank you very much. I want the group to be sure they understand that all details of the study and the aspects of consent must be applied, part of the application to the FDA for approval of any ethics study. So that would concentrate our needed attention on those requirements, the first of which Neil covered quite well, the challenge and the difficulty of deciding who is a patient who can give consent. Obviously, a patient who is unconscious cannot provide consent and can only be enrolled under EFIC. So that's clear. But many of us have seen shock patients that are perfectly conscious and conversational, and we would need to identify at least principles of how, let's say, two physicians might decide that somebody is unable to provide informed consent, even though they are able to articulate a few words. The second area is how exactly, with a study like this, we would provide community consent and public information. Public information through the media and through social vehicles is obviously open and would be done. But for example, with the cardiac arrest studies, a lot was done repeatedly with random digit dialing and requiring that 90% or so of people responded either yes or no, but listened to the presentation, and at least 80% said they would agree to participate in the study. My concern about random digit dialing is all the confusion that exists now, which is much more intense about phone conversation. So I have some doubts about achieving a 90% success. And if you don't achieve success by the random digit dialing, randomization of digits, but have to wait for somebody who's able to, willing to respond, I'm not sure that would be constituted as good consent. So some of our discussions have been on the idea of patients who have recently been hospitalized successfully for ICU or cardiac care admission for heart failure or acute myocardial infarction might be encouraged to sit in a discussion group in which they would ultimately be asked to approve or not approve whether they would want to participate in the study as proposed. And then finally, this business of every available relative patient must be given the opportunity to opt out. And that opt out or refusing to be randomized has to be protocolized. You have to submit to the FDA the wording of the statement you would make. And that becomes a very complicated and difficult issue about which we would have to spend a lot of time talking with IRBs as well as ourselves as reasonable investigators as to what we would want to say about a study before saying, do you want to refuse to participate? So those are my comments.
Dr.
Thank you,
Weissman,
Catherine.
do you see difference between consenting post the procedure versus non-consenting at all using the EFIC versus just doing the consent after the procedure when the patient...
May I respond to that?
Please.
We're not proposing retroactive consent. That would not be allowed under the regulations. We're proposing a mixed model of if the patient or their LAR is able to consent, you need their consent to enroll. If they're clearly not able to consent, then you would be able to enroll them under EFIC. And if it's a gray area, and as Neil said, gray remains gray, you would give the patient or their LAR an opportunity to opt out of enrollment. Anyone who opts out would not be enrolled. Under the EFIC process, you are always allowed to, or you're always actually required to obtain informed consent if it is feasible. In practice, we've never done that in the cardiac arrest trials because it's never been feasible, right? I'm not meaning to be glib or insulting, but it's kind of hard to get informed consent when someone's in cardiac arrest. But we've always had a mechanism to do so if it were feasible. It's never been the case. Catherine?
Yeah, thanks, Graham. So I just wanted to make a couple of clarifications. The diagram, the first diagram, I just wanted to make it clear, and I think Mike said it as well, that that diagram takes place once a study has already been approved for EFIC. So the situation that Graham is talking about consent capacity, once the subject is identified, is part of an EFIC study. So you are trying to obtain consent, more consent than an EFIC study would generally what's the word I'm looking for? Not allow, but expect. So you're trying to do due diligence and trying to enroll more subjects under informed consent. So I just wanted to make clear that that diagram takes place once the study has already been approved as an EFIC study. The other clarification I just wanted to make is studies are approved for EFIC individually. So the reviewing office receives a protocol and they review the study if it's being requested to be performed under EFIC. Sometimes they'll bring it to the 5024 board. Each one is looked at individually and approved on an individual basis. So that's one of the reasons why when we tried to bring this more general diagram to the board, we just can't make any definitive statements based on general information. We have to have a specific protocol. And part of the EFIC approval process obviously includes that the sponsor has thought out all the other possibilities of making this a consenting study. So for example, within the therapeutic window, can you obtain consent from the patient or the LAR? Can the short form informed consent be provided? Can the patient population be identified ahead of time? And can you obtain prospective informed consent from the patient or the LAR? Can the study be performed only in the consenting fraction and still have the results generalizable to the non-consenting fraction? Or can the two different populations, consenting and non-consenting, be studied under two different studies practicably? So that's all I had to say.
And by way of conversation, not to contradict Catherine, we considered many of those issues in our small group. The FDA EFIC board interprets the regulations and the guidance document as an EFIC study can only proceed if the majority of patients cannot provide informed consent. leaving Catherine out of the we believe that the guidance document allows in conduct of an ethics study if you've met all the other conditions, and the risk, as it says on this summary slide here, the risk profile of those able to consent differs from those who are unable to consent, and a large and important, but not necessarily majority of the population is unable to consent.
So I'm just going to jump in first of all, and kudos to this group for laying out what I think is one of the thorniest areas of any of the working groups out of the SHARC program, in really a way that has emerged very uniquely and has just been summarized very eloquently. So what I want to ring everybody's bell for is that, to my knowledge, and I've been in almost every one of them, this is the first time in ARC history that we've actually tackled an issue centered around definitions required for informed consent. And in this case, the definition, I think Neil pointed to, and it's still up on the slide, in the setting where some people worry about informed consent, not just using up the therapeutic window, but transforming a salvageable setting to a non-salvageable setting that's going to result in death in a very short time frame as unethical. So welcome to this unique world. But the flip side of that is, as I think Neil and others have shown in previous meetings, the concerns about EFIC creep, and are we going to be doing experiments on people without their permission, and as you get into this middle zone. So as Mike said, unconscious people, that's easy. But what if they're actually conscious, they're looking at you, they know their name and the date and the president, but you can just tell they're not right to digest the implications of research. This is tough turf. So the definition part of this, that is the reason this group is part of the ARC program, is really to define where and how we define that line in the sand. So a physician or a SHARC team up front can actually, in a patient and LAR encounter, get it right on a reliable, consistent basis that can be followed over the course of doing trials, so that we have the whole population and not just part. So the methodology of doing it and the digital calls requirement or the community involvement requirement, that's methodologies, but the definitional part here, I think, is really the toughest that the group has put on the table, is where is the line in the sand for, as I think Neil highlighted the blue, or Graham highlighted the blue boxes. Where does EFIC apply? And how do we define practically immediately on the front line this patient who's in the blue box versus not?
I think the challenge for us is, this is a lot to cover in half an hour. We could have clearly taken more time. But I think the challenge, as we talked about this, is clinically, we clearly meet patients who sort of don't get what's going on. And we think some, but not all, patients with cardiogenic shock would be like that. But there is no precise objective measure that we're aware of to do that. I think we need to, as we go forward, present a specific proposal to FDA for a specific study and learn from that. But I imagine that would include sort of training of research staff before study initiation with sort of scenario practice, and sort of monitoring the proportion of patients enrolled in under each category and throughout the trial conduct period, but also doing it in a manner that it is auditable, much as in current trials conducted under EFIC, we have to monitor the time to notification after enrollment and report it to the DSMB. And if it were an FDA study, we would have to report it to FDA too. It sounds complicated. I think there's a process, although it's still a sort of all a testable hypothesis. Sorry, Neil.
No. So I think, Mitch, to get at your point very directly about sort of definitions and criteria, that, you know, this really is going to be anchored in a definition of what it is to provide consent for a research study, right? In a sense, the minimum, what most people would say is you have to understand the risks and benefits of what's being proposed and what that means for you, right? You have to be able to apply it to your own situation and make a voluntary decision. Some people would question the voluntary aspect in this case. I don't know that I don't think that's where the money is. I think really it's in this initial situation, it becomes very clear that this is not someone who can engage in a discussion of the risks and benefits and apply it to their own medical situation. And so I think the idea would be that we would use, and we have an example of one that's been used before, but a very brief script saying just the very minimum about what's happening. And if it becomes clear that there's an opportunity for moving forward to a consent process, you move forward. In many cases, it won't be. And that's when you've had that opportunity to sort of engage in the process and they have an opportunity to say no. So I think that's anchored in a definition of what it is to give consent. I think it's also important to recognize that there are various ethical functions that this process serves, some of which are substantially advanced by trying to give people an opportunity to opt out like this. It doesn't do everything, but it does advance some important ethical functions.
And Neil, and Graham, do the considerations change and do the process change if it's comparative effectiveness research where you're comparing two approved therapies that Ron might choose one, and if Alex were standing next to him, might choose the other. They're both approved. They're equally justifiable based on available data.
I think that's actually a question for Catherine. Catherine,
oh, thanks.
You want to opine on that?
Thanks, Graham.
So go ahead.
So, you have to follow the regulations in 5024, no matter what the device is. So I think the simple answer to your question is no, it would be the same.
Yeah, I think the regulations, and for Catherine on this, it's very clear the regulations do not address this distinction. I happen to have a large grant application right now to address this very topic about comparative effectiveness research in the context of acute care, which I think is a really thorny issue because the stakes are high, right? It's not just like, antihypertensive drug A versus B. The stakes are high. You're looking at major outcomes, and that I think makes it more complex to think about this as sort of the alternative would be to call it minimal risk research, right? And that gets to be, I think, in some cases, a tough pill to swallow when you're looking at major mortality outcomes. So I personally think the thoughtful approach doesn't change. I think the extent to which you expect people to be involved and the details you might want to provide to people in an ideal situation are very different in those two circumstances, right? It would be a very meaningful thing to say in a brief opt-out script. We're doing a study looking at commonly used therapies for this condition. Everyone is being enrolled unless they have an objection, for example. That's different from we're testing out a new device, right? When you tell people one versus the other, that's a very different thing to tell them. So I tend to think that distinction is made at the approach level rather than at the regulatory level.
Well, Neil, as you mentioned, it's also at the fundamentals of human subjects clinical trials. So the point you were going to say, and we're going to flip a coin as to which of these we're going to use, and we're going to publish these results.
Yeah.
You're already in a line where attention to informed consent is part of the package, whether these are investigational devices or or approved devices.
Although to Ron's point, I think there are other areas in critical care where these trials are actually done frequently with, there's obviously a spectrum that starts somewhere with chlorhexidine versus not,
That's right.
where patients they are randomized, but the consent is only obtained afterwards for use of the data. And that's what has allowed many non-cardiology critical care trials to move forward and answer the questions.
And it gets
I think
deeply.
the issue there is the interventions are low risk.
Yeah, no, and there's clearly
They're clearly not in this space.
It's not low risk.
Yeah,
There are also
that's the issue.
There are also deep questions about the nature of the design, right? You could, whether it's at the level of the individual patient versus protocolized, and you would think about, would this be different if you did this in a sort of cluster design versus in an individual randomization design? All of these things have potential to complicate every aspect of this determination of, and is really, I think, an area of substantial regulatory lack of clarity in comparative effectiveness research. And
I applaud your grant, because I think in some ways, at its essence, the consent applies to the risk of the research, not necessarily the risk of the device. An extreme example of that is, I want to use a blue Impella versus a purple Impella. Right. And there's no difference in the risk between the two devices that you might use. But obviously, putting in an Impella, you're putting it in a high risk situation. And so I recognize it's very complicated, but I think sometimes we are applying a rule that's really devised for a new experimental intervention compared to something that's a very different risk. Whereas in critical care, often we're trying to compare two things that have equal risk, for which we really don't know which has better efficacy. There's truly equipoise, but the timing is essential, and it's impossible to conduct the trials in a situation where you need consent.
The only thing I would just add is that cardiology is not alone in struggling with this. There are many critical care trials that are struggling with exactly the same thing. There's some, as you mentioned, that have come up that were able to navigate a different path. There are others that have run into exactly the same problem. And one of the biggest worries has been, and I don't think this has been the case, that the language in the EFIC regulations that the existing therapies have to be considered unsatisfactory or unproven. I have worried for some time that might actually prohibit comparative effectiveness research. And at least so far, that does not seem to have been the case. And I think in this kind of context, that probably would not be a barrier to studying different therapies that are already in practice, because we all know they all have potential ways in which they're not sufficiently proven or not sufficiently satisfactory.
So I don't know if we still
Okay, I think we're at time, aren't we?
No, you do have another 10 minutes. I actually like to hear what the FDA says about it, because my concern that if we're not going to have a creative solution and we're just going to enroll patients in A, B, and maybe beginning of C, and we're not going to be able to enroll D and E, so that's going to be bias the enrollment of those studies. And maybe one other question to you, Neil. I didn't see in your algorithm an option, maybe there it's not possible, to take a referee like a neurologist who is not part of the study that would actually determine this patient should be eligible to be in the study without a consent because of his neurological status. Do you consider to add that to the algorithm?
We talked about that extensively within our group, and I think there's two principal reasons why I think that strategy is unlikely to be productive. One is the simple issue of time, right? Bringing in an additional consultant to come and see the patient in the context of something like this is going to be quite difficult to operationalize. All of that, again, hinges on the therapeutic window, and that structures everything and is going to be protocol specific. So if you have that opportunity, there may be ways to do that. I will tell you too, I think that is a challenge, because in many cases, you're going to be making this assessment of a surrogate or a patient who's just distressed, right? They don't have, the issue is the nature of the barrier is not one that specialty expertise is really good at picking up. So calling in a psychiatrist to talk to a patient before they provide consent to go to the cath lab, I think it's hard to know how they would even start to engage that process. So I think the nature of the barriers are different from what we see in other kinds of contexts where those kinds of colleagues can be more helpful in assessing the nature of a patient or potentially an LAR's cognitive function. So I think the time issue and the nature of the impairment sort of mitigate against that likely being productive.
Yeah, I didn't.
Catherine or others from FDA, do you want to comment?
Yeah, hi, this is Bram Zuckerman. Graham, let me make a few comments. Number one, I want to really commend Graham, Neil, Mike Weisfeld, and your team for putting a legitimate proposal on the blocks. I did have the chance to talk with our center director yesterday, and certainly he is very interested in finding a way forward. And the way forward to test this proposal is the way that Catherine and Graham indicated, that we do need a specific device proposal. And I do see that Chuck Simonton is part of this conference, and certainly I will follow up with him offline because I don't know how comfortable Chuck is really right now talking about his potential prospective trial. But regardless, I do see merit in further talking about this general proposal, Graham, with our center director, and we'll follow up with you all because even before we get the specific device proposal, I think it's important that you present it to our senior staff with all your caveats and recommendations so that we can flesh this out. I know that you, Mike, and Neil are consultants to Abiomed, so that I hope you can share your slides with them and also send me a copy right after this meeting with the caveat that they are draft slides. Chuck, do you want to make any comments at this time, or do you want to talk offline?
Happy to, Bram. We've announced probably for about a year, Abiomed is moving forward. With diligence, we're trying to get a little bit closer to it with a prospective randomized trial on AMI shock with shock under 12 hours, employing the best practices that we've learned from the big registries like the Shock Working Group and NCSI for the management of shock. And this is the biggest hurdle that we need to get over in terms of having a successful study, because the patients that can't give consent are clearly patients that you don't want to exclude from an important study like this. So this is, we've talked to Neil and to Graham, and Dan Burkhoff has reached out to our leadership, not just me, but our academic leadership. Dan, Greg, Bill O'Neill, Naveen Kapoor have reached out to Neil and to Graham. And Dan has also spoken with Myron. So it's great to start getting their input. So we're really looking forward to having them become integrated into this, the academic group that's designing this study and helping us make some progress, because we've got to be able to get there with a potential ethic document that FDA could endorse, which would then help the individual IRB chairs have more confidence they could move forward with an ethic at their specific site. Following all of the traditional measures that have been done before with community bulletins, community consultation, and trying to do that in the most time efficient way possible. Otherwise, it could take years to get there and to get anything started. So it's an opportunity for a really novel approach to this. We're really excited about it and appreciate the input from everybody. And this group is fantastic. I mean, CSRC with the SHARC and now with the framework for an ethic and with FDA as a partner here, I think we can really make some progress here.
Thank you, Chuck. I will be in touch.
Thank you both for those comments. We have been deliberately device agnostic. These slides will be available. I note that there are a bunch of supplementary slides containing information, including a sample script from a prior study and information about community consultation and public notification. I encourage you to look at that. We did not obviously have time to do that in the time we had. I would like to clarify, going back to the figure, in our thought was that the focus of interest was a STEMI population with cardiogenic shock, and as the non-cardiologist in the audience, I think we're probably talking about primarily stage C patients, stage C, D, B. I mean, since they haven't got cardiogenic shock yet or are in the process of developing it, I would expect you would be able to consent them before enrollment generally. And to me, that's the sort of crisp AMI population. Type E patients, that's to me, that's the impressed population. And almost all of those you couldn't consent because they'd already had cardiac arrest. So I think this framework which we're proposing, which as Bram and Chuck have said is sort of a testable hypothesis, is intended to apply to type C patients.
Yeah, Graham, so this is Mitch. I think very importantly, to make this feasible to not be the whole ARC paper, but actually to be a part of the ARC paper, it would be worth, because there are so many issues regarding the nature of the physiologic syndrome, the therapeutic window, all of those sorts of things, that starting with acute STEMI shock is something that would be a good way to introduce this in the ARC paper to narrow down the definition, as you say, to that sort of middle zone of these are the patients who definitely would fit EFIC. These were patients who is a little more fuzzy, but probably would make EFIC. The conceptual, unable to engage either the patient or the LR or both, I think we're going to need a little more granularity than that. So that's where I would put the punch for
that's fair. That's fair.
ARC component, just to make it a reasonable word count. I would just start with the outline of what is the kind of trial in this shock setting that meets the criteria, and then get down to, and how do you define then within those patients kind of who's who? Because
I think that's consistent with what the four of us have talked about. Again, not wanting to put Catherine on the hook as giving an official opinion. I think the challenge is whether for research or clinically, I think we struggle sometimes with patients who don't quite understand what is before them, and on occasion I've had psychiatry come and do a competency assessment. It just, for multiple reasons, it doesn't happen quickly. That just seems markedly impractical. So we think we're going to have to rely on the good intentions of the researchers and have them documented. It'll take effort to train them, and we'll need to get them scripts as to what needs to be documented, date and time it. And I think it needs, this is more a regulatory perspective than a clinician or a researcher perspective. I expect DSMBs and IRBs and FDA will want to see that information included in their periodic reports to verify that people are indeed acting with good intentions.
Okay, so This is a very encouraging first draft, Neil, Graham, and Mike. Before we end this session, I'd like to ask Catherine, Andy, Mayor, if they have any other suggestions for what should be included in draft 2 slides that would be presented to Dr. Shurin, our center director.
So this is Catherine, and I'll start. One thing that's going to be the biggest challenge, I think, with any protocol that comes to FDA requesting EFIC is going to be demonstrating that consent cannot be provided by the LAR and or the patient. So that consent capacity piece, we've generally had very objective data to be able, when we've had other EFIC studies, like Graham says, with cardiac arrest, it's very cut and dry. This is a very gray area. So I think that is going to be the biggest challenge, is coming to the FDA with empiric data that demonstrates that these patients and LAR would not be able to feasibly provide consent within the therapeutic window.
And we, to respond to that, Catherine knows this, but so others are aware, we think some of that data exists and some of it may not. So there may need to be some prospective data collection to define those items before any sponsor can get approval.
Neil, any comments on that point?
I agree with Graham that I think there's a role for data in this space to understand expectations that surrogates and patients might have in this context, as well as to assess their ability to engage. I think that could be really productive in helping to make the process as patient-centered as possible. Because I think ultimately it's really key to recognize this is not about avoiding consent. This is about trying to make this interaction appropriate and context sensitive. The only thing I would say with regard to the notion of objective data about consent, I think in many cases, with most EFIC studies, it's less that there are objective data that they can't consent, as that we've been dealing with populations for whom there just isn't any question, right? So I think there's an open question, and this would be helpful, I think, for all of the research community. I think this is an area where FDA and all of us can partner to clarify what kinds of data would actually be most helpful. Because I think there are investigators that do struggle with this.
Okay, so what would be helpful for us, and I'm not sure which road we're going to go down and if this will be necessary, but, you know, make a proposal. Hopefully it's relatively simple so that we would have something to react to. You're the acknowledged expert.
What would be helpful in terms of those criteria?
Yeah, to get some more data.
In terms of, well, go ahead.
Sorry, Mitch, just to think out loud, you know, one possible step, and I think we're going to need to move on, even though we could spend the rest of the day diving into this. But as always, I would lean towards, why don't we start with what's easy? So if you have patients who clearly can be consented, that's easy. If you have patients who are unconscious or obviously confused beyond articulate communication, that would be a group who I think would be pretty easy to identify. And while we wouldn't necessarily put a psychiatrist or a neurologist, we probably could at least get 2 doctors who would agree that this patient is out of it. And then sort of back into the middle group, who patient seems a little altered, or there's an LAR present who doesn't seem to be able to connect, but put the harder stuff downstream, start with what's easy.
I mean, I personally think what would be most helpful would be, what's the right way to say? I'm a little unclear about what we would ask from you and what we would want to provide. But let me tell you what I think would be most helpful to provide, and I think learning whether that would be helpful to you all is very instructive. And that would be data from people, as Graham alluded to, and I think Mike did too. Data from people who have been through this situation, about both their ability to engage and what they might think would be a reasonable expectation of their involvement. I think those data are gettable. We've done studies like that before in analogous populations. It's very doable, and I think incredibly valuable to understand what, because ultimately this is about what is this going to mean for people who would be enrolled under that pathway. So I think knowing whether those kinds of data would be helpful to the FDA in making a determination would be, I think, a license for doing that kind of data collection and providing it as part of an application.
Yeah, and we need to move on. This is a great session. I personally learned a lot and how complicated this. But you know, our time is up, and I think we will continue offline with this providing data. What is the time? How much you can make it closer to cardiac arrest? There's a lot to deal into that one and to be creative. But now that we have a definition and we have a consent form and the patient enrolled into the study, I think we should move to the next session, which deals with the standardization of the clinical outcome of shock research. So the leaders of this group is Ernst Spitzer, Eddie Fan, and Alistair Proudfoot, and I guess Spitzer, Andy, you'll take it, Ernst?
Yes, thank you very much, Ron. I will share my slides. Just a second, please. All right. So we will present session 4, standardizing clinical outcomes for shock research. We worked together in the past months with Alastair and Eddie. And basically, we divided the work as described in the slides. We identified key outcomes for shock research. We leveraged as much as possible from prior ARC initiatives, and we standardized or brought proposals for standardizing definitions on those key endpoints that we will discuss later. After the end of the presentation, we would like to start a discussion in some open points. So how did we prioritize endpoints for shock research? We looked at those endpoints reported in previous shock trials, as well as those definitions that have been standardized in other ARC initiatives or in other standardization efforts. And from those, we classify them as high priority, intermediate priority, or low priority. And in the list of high priority, we ended with 9, which are death, MI, heart failure endpoints, stroke, including intracranial hemorrhage, bleeding, vascular complications, health-related quality of life, activities of daily living, and disability. Later on, we added days alive out of hospital, and vascular complications will be addressed in session 5. So now I'm going to present the proposed definitions for death, MI, stroke, and bleeding. The references we used are this document from 2017 from the Standardized Data Collection for Cardiovascular Trials Initiative. And then we looked at the Heart Failure Collaboratory and ARC, the ARC2 document, and the Valve Academic Research Consortium 3. We think that the most consistent classification, which highly relies on what was proposed in 2017, is this one. So this will be the table that will be circulated with the other working groups to accurately classify death following cardiovascular death, non-cardiovascular death, and undetermined death. The beauty of these definitions are that in the supplement of this document in 2017, we have a specific information to classify each of them, and that's very helpful when we go through the adjudication process. One of the questions that will remain for later discussion is whether we should call it death resulting from heart failure or pump failure, but that's a minor detail. Immediately we noticed that discussing about relatedness assessment, whether it's related to the procedure, the device, or even related to shock, is extremely important, but this will be also addressed in session 5. Myocardial infarction, as we all know, has several definitions and remains a complex endpoint. we studied the fourth universal definition, ARC2 definition, the VARC3 definition, and the heart failure collaboratory and ARC document, and we concluded that the VARC3 document provides the most comprehensive and potentially applicable definition, which adapts the fourth SKY and ARC2 definitions, providing all the types of the fourth universal, so type 1, type 2, 3, although PCI is not the key aspect of these patients, but these patients may undergo PCI, so we maintain that classification, and we have the type 5 for other cardiac procedures. So we would suggest that this same definition is used for any other cardiac procedures, specifically because CKMB has been associated with, has a tight association with outcomes. So we would suggest to maintain the VARC3 classification. As it relates to stroke, we again looked at the document from 2017, the Neuro-ARC, which was published at the same time, and the VARC3. We suggest that the VARC3 document is used as reference, which classifies a stroke as overt CNS injury, and then subclassifies into ischemic stroke, hemorrhagic stroke, and a stroke not otherwise specified. It also includes definitions for symptomatic hypoxic ischemic injury. And for those trials where imaging is mandatory, we could assess covert CNS infarction or hemorrhage following definitions of Neuro-ARC. VARC3 simplifies the table that Neuro-ARC suggested, thus we would suggest to keep the VARC3 table. And TIA is also defined, and delirium without CNS injury. Importantly, stroke grading for acute stroke severity is also according to the NIH stroke scale classification, and stroke disability according to the modified ranking scale. In terms of timing of endpoints, we would suggest that it's used consistently for all endpoints, and I will get back to that later on, but it's consistent with the Neuro-ARC and with other ARC initiatives. For bleeding, we looked at the seminal BARC document, as well as the VARC3 definitions and the consensus statement of the mechanical circulatory support ARC. And we think that the table proposed in this last document would be easiest to use or more consistent with the indication, which uses the same classification or types that BARC described, although we would suggest, as in other ARC modifications of the BARC table, we would suggest to modify type 4 as procedure related, and maybe there are other additions that need to be reviewed later on. As well as in the MCS ARC, we would suggest to classify this as patient related, management related, pump related, and device related, but again, device relatedness is an entire separate topic that will be addressed later on. Then we move towards heart failure events. And again, we reviewed the 2017 consensus report, the VARC3 definitions for heart failure, and the heart failure collaboratory and ARC document. And we would suggest to keep the recommendations of this last document, which define heart failure events with hospitalization and heart failure events without hospitalization. And there are precise criteria that are very detailed and specific and can be used for data capturing the EDCs as much as for endpoint adjudication. We would suggest also that if possible, all hospitalizations are ascertained with all cause, and this later classified into cardiovascular related, and whether that's heart failure related and non-cardiovascular related. And of course, there could be cases where hospitalization is of a known or undefined reason. Also, elective hospitalizations would not qualify as an event, and that's consistent with most updated recommendations for SAE reporting. Thus, it's important to capture whether these are elective hospitalizations. And coming now to the timing, we would propose to consistently classify the timing of events as peri-procedural when these are related to a procedure and they occur within 30 days after the procedure or before discharge, whichever comes last. There is a sub-classification into acute and subacute. And early, and this would be early for any event, not only mortality, but between 30 days and 1 year, and late events beyond 1 year. That relates to the timing of occurrence of the events. And as it relates to the timing of reporting or the time points that should be captured at follow-up, we would suggest to use in hospital 30 days, 180 days, and 1 year at minimum. There could be other time points, of course. These are points for discussion that we may want to address later on, whether we want to capture worsening of heart failure without hospitalization, the methods of data collection that are pragmatic, whether that's administrative data or whether we require source documents for ascertainment of the events or classification. And finally, whether it's required to define an optimal medical therapy score for this population. For this next session, I would like to invite Eddie to continue presenting.
That's great. Thanks, Ernest. So, for this section on this final section on health-related quality of life, activities of daily living, and disability, our group really less focusing on the definitions per se, but with the sort of idea of a lean CRF, we also want to approach this as what are the core sort of patient-reported outcomes that might be considered in shock trials and shock research, and that's how we came upon these three patient-reported outcomes to consider. So next slide, please. And just an overview again, I leaned here as also not a cardiologist from the critical care space, where quite a bit of work has actually been done looking at core outcomes and what needs to be reported in critical care research. And certainly these shock patients qualify as severely critically ill patients. So some of that work has been done sort of through methodologically rigorous processes using sort of modified Delphi or RAND procedures or OMERACT framework to look at core outcomes in critically ill patients, one led by Dale Needham, an NIH R24 sponsored research in acute respiratory failure survivors at Johns Hopkins, and work that we've done through ECMONet, looking specifically in the ECMO space, what core outcomes might need to be considered in trials of ECMO, both for cardiac and respiratory indications moving forward. And in the bottom left panel here, you can see sort of just an example of where we worked from, some of the life impact core outcomes that we would consider in ECMO therapy, and some of those are represented here. And on the right, some maybe, as Mitch said at the beginning, some aspirational ideas that we want to bring for discussion, an outcome that might be quite patient-centered and has been used actually in the cardiology world. In fact, days alive and out of hospital, which is now gaining, I would say, momentum in the critical care space. We're using actually days alive and out of hospital as the primary outcome in a number of registry-embedded ECMO trials that we've just started. And it exploits, both a patient-centered approach as well as methodologic advantages of using an ordinal scale as an outcome that might help with power and screening requirements for trials. But nonetheless, we'll get back to the days alive and out of hospital briefly at the end. Next slide, please, Ernest. So for our sort of recommendations of what we might consider core patient-reported outcomes, we thought about health-related quality of life using a generic instrument like the EQ-5D, assessing daily activities of daily living using the Lawton Instrumental ADL questionnaire, and assessing disability using the modified Rankin scale. And again, as Ernest had mentioned previously, we sort of considered, and again, this open for discussion, that we might consider time points of having a baseline measure of these factors at 30 days, 180 days, and at a year. Next slide, please. So here we're just proposing a number of, again, so the first sort of overall view that we took on this was to agree on what core sets of patient-reported outcomes could be considered in this segment. And here's some proposals for validated instruments that could be used to measure those core outcomes. These are by no means final, but just again, drawing from our work in the critical care and ECMO space, this is what we'd come up with. The EuroQol or EQ-5D, the 5-level self-reported questionnaire of health status, is the world's most widely used measure of generic health-related quality of life. It's only 6 questions. It only takes 2 minutes to complete. It's already been translated, I think, into over 50 languages. And for research at non-commercial purposes, there's no license fee to use this for research. The other advantage of using this instrument is that it can be translated into utilities and weights for cost effectiveness research. A lot of work has been done in many different jurisdictions to help translate this into utilities that could be used to look at cost effectiveness, which could also be a very important aspect of shock research. An alternative would be the short form 36, which again is a generic health-related quality of life instrument. It's much more cumbersome, it's longer to administer, and more difficult for patients to complete. Next slide, please, Ernest. Activities of daily living, again, I think we're all very familiar with this sort of measure. It's really just a checklist or self-reported physical function and independent living. This instrumental ADL questionnaire, you can see the questions on the right. There are only 8 items. Again, it takes minutes to complete. It's freely available. And again, this gives a better or more holistic view of what the patient is able to do rather than the sort of simple alternative, which is the CATS ADL checklist, which asks things like bathing, feeding, and that sort of thing. This gives a better sense of global functioning of the patient than just a simple checklist of ADLs. Next slide, please, Ernest. And then finally, disability is very important. And again, this might be familiar to you. It's been used in a number of cardiac arrest trials, most recently the TTM2, but using the modified Rankin scale, again, which is a single item global scale of disability. It can actually be done both objectively through direct patient observation or interview, but it could also be administered and obtained through a telephone interview, either with the patient or with their surrogate. It takes about 5 to 15 minutes to complete. And again, the advantage is that this is a freely available scale. An increasingly used alternative, and again, at least in the ECMO space and through the ECMO network, we're thinking about changing this to the WHO's disability assessment scale, or the HUDAS, which is also very quick and it's been actually designed to be administered by telephone. Also freely available and very easy to complete. But again, these are just sort of proposals for validated instruments that could be used to measure something important like disability. Next slide, please, Ernest. I think this is the final slide. Again, much of this might be observational, but aspirational, as Mitch sort of mentioned at the beginning, but just a sense that, again, amongst our core outcomes, it might be very important to consider the inclusion of patient-centered outcomes. And again, chief amongst this, maybe not for the publication to come, but eventually as per like standards for core outcomes, like the COMET initiative and the COSTAD statement for how these things are done, we really need to consider including patients and their caregivers as representatives and important stakeholders in deciding what outcomes are included in SHARC research. I think that would be key. And again, this idea that days alive and out of hospital might be such an outcome that's sort of more sophisticated than mortality, which combines some of those features that could be important and more patient-centered than just measuring mortality alone. Of course, there may be some logistical challenges, which is outlined on this sort of graph on the right, in terms of we might increase the patient-centeredness of some outcomes, but of course, pragmatically, to measure some of those might be more difficult. But again, it might be an important discussion, both from having patient stakeholders to consider this outcome, but it, again, at least from a SHARC research point of view and in the ECMO space, we've been considering it because it also has some statistical and methodological advantages of using an ordinal scale as compared to a binary or dichotomous outcome, or even if you consider these scales as a continuous measure. So REMAP CAP, at least, it has demonstrated some of these advantages using endpoints like ventilator-free days or hospital-free days as an ordinal scale. And so these are just interesting things that we wanted to bring to the group for future discussion. So I think that's the end, Ernest.
Thank you very much.
Thank you.
Any other comments, Ernst, or shall we let Alistair? He was part of the group. I mean, to comment as well. I don't know if he's.
No, I'm languishing in a cold, so that's why I handed over the reins to. So I just open up discussion. I think for us, I would guess that a lot of the group will probably think that we've picked atypical patient-centered outcome measures, and things like KCCQ haven't come up, and clearly that's up for discussion, but hopefully Eddie's given a good understanding and rationale as to why we focused on the outcome measures and the PROs that we've bottomed out at.
Great. So it is open for discussion. Maybe I'll just start with a short question regarding surrogate markers versus clinical outcome. Many of the studies obviously are underpowered for full clinical outcomes, and they're leaning on some surrogate markers. I mean, do you want to relate to this in terms of it's still also outcome, but.
That's a great question, Ron, and we discussed that among the group. We tried to work based on a hierarchy of endpoints and came out with the proposed endpoints as clinical hard outcomes and other outcomes. And we wanted to prioritize patient-reported outcomes. I think that's something special about this ARC initiative, and maybe Mitch can comment, but I think we haven't detailed so far patient-reported outcomes in any other ARC initiative. But as it relates to biomarkers or surrogate endpoints, yeah, we thought that would open a new chapter. It was so comprehensive, so broad that we thought maybe this is the right time to discuss and whether the group considers we should also work on that. That we considered hemodynamic markers, biomarkers, imaging, for instance, and Lester proposed many of those. But then what do others think about including those in the SHARC definitions?
Mitch?
I think it's always a good idea to, I'm sorry, Eddie, you want to chime in?
Well, I just wanted to mention, like, maybe also, Mitch, sorry to interrupt, like we and also part of the discussion that we had, the three of us, at least a consensus of three, is that probably some of these surrogate outcomes are very much dependent on the intervention or the study that you're going to design, because you want a surrogate marker, right, to be sort of responsive to the treatment or intervention that you are using. So it could be very specific to the trial that's being designed, and obviously tightly associated with an outcome that's very important to a patient. So anyways, but interested to hear everyone else's thoughts about that.
Yeah, before Mitch gets into that, the reason that I mentioned that, because again, I'm going back to the definition. On the definition, we place a lot of categories on the phenotypes that determine, even by the original definition of what is shock. So if you can revert those with mechanistic studies and improve any of those definitions that brought you from A to B or B to C or C to D, and then you can de-escalate as well from D to C and C to B. I mean, I know that some of those, like cardiac power, was used in the past, which is not part of the definition, and others. So I'm interested what other things about it. Maybe I'll start with Mitch.
Well, some great questions, Ron, and so let me take a half step back, not a full step, but to at least commend this group for again really doing two things. One is leveraging what's already out there, which is the fundamental to the philosophy of ARC is don't reinvent the wheel. And I think this was just a plus exploration of where are there already definitions that are likely to be fit to purpose. I think the spectrum of definitions, including what Eddie just wrapped up, and patient outcomes, the surrogate markers, and then the the obvious side of shock, that mortality is so high that you would think if we had an effective treatment, you could reduce it. But after 20 years of wrestling with that, I think there's more to it than that, as we all now understand. Part of it is the complexity of the definitions coming in. Part of it is the way and style and speed with which we can use support interventions. And then part of it is just the complexity of what comes out. So I think composite, hang on one second. Composite endpoints to me would be the place to start before surrogates. How many end organs really are irreversibly damaged? Brain, lungs, kidneys, heart, or death. A big part of this, I think, is not only understanding if we make a dent in mortality, but if we don't make a dent in mortality, do we make a dent that's a hard, measurable benefit to the survivors? So if we have different kinds of survivors with or without a given device, I think that's important to capture. Surrogate measures to me are more likely to be device-related endpoints. How quickly does a device kick in or shift the physiology or begin that traction? So I think it's very important for device-related evidence, but where a blood pressure or urine output or whatever surrogates to me, I think, are going to be less, at least from my focus, on primary endpoints of outcome. and more device related, just to understand how technologies kick in, augment one another, or create safety problems by being used overly much. And then I think again, we're going to need an aspirational bucket. But to me, one of the key areas of the aspirational bucket is, and how do patients feel about this? And Eddie, you, as you did in sort of the work up to this point, you shared just an incredible depth of perspective in ways to practically try and get at the patient's side of this simply as possible. That being said, what's really important and how to make a decision on which approach is the best approach to go forward with, I don't know if that's going to be by the end of this paper. But absolutely, I think we got to put it in the aspirational bucket of that needs to be a piece. So I'm in for multiple end organ composites. SHARC is a systemic assault. It may be precipitated by one organ, but at the end of the day, to me, the measurement is, can you impact mortality? Sure, but probably it's going to be challenged. But of the survivors, do you have a measurable difference in end organ function as a composite? Would be a place that I think would be interesting for this group to consider as a place to start.
It looks like there are a couple of hands raised. Graham, Tim.
I've used the EQ5D in a trial years ago in part 2. It's very simple. I think that's its most redeeming feature. We really had a scattergram when we administered it every 3 months of over a year and couldn't make any sense of the values. We were actually the first to use the modified ranking in a cardiac arrest trial, stimulated to do so by Catherine and Bram. It's a good measure, but it's really more a neurologic measure. I'm not sure it's applicable to this population. An alternative approach to consider might be the Health Utilities Index, which has some of the properties of the EQ5D. It gives you both a generic quality of life measure and a utility score, but it also has ratings on 5 or 6 almost disease-specific measures. I would encourage you to look at that. It takes longer than EQ5D, but not as long as SF36, and there's normative data available for it.
I'd like to hear from the FDA. Maybe John Saperstein, you want to give your thoughts about it? If you're with us, I'm not sure, or anybody else.
Well, and Meyer has his hand up.
Yeah. So 2 things. I think the FDA is very interested in patient-related outcomes in all of those measures. However, the term surrogate has been used. For the FDA, the surrogate has a very specific meaning of a certain validation of terms of long-term outcomes. And all of the measures that's been discussed today are of interest, but we considered intermediate outcomes. So just in terms.
Yeah, I think that's a really important point that you raise, and we should address the difference between surrogates and intermediate endpoints. I want to go to Tim, who also has his hand up, but I just, back to the sort of PRO, discussion, since we include heart failure, cardiogenic shock, and because the FDA includes the KCCQ and the Minnesota Living with Heart Failure questionnaire in its device development toolbox, although acknowledging these aren't good acute measures, we may want to think about mentioning them as well. Tim, your hand's up. Do you have a comment?
No, I think that's a lot from before. So
okay.
Well, the only comment that I will say regarding the mortality, this is definitely the most strongest endpoint. But to me, even the option to de-escalate the therapy would be an important outcome to report. So again, patients may not reach survival because some other things like infection or complication of procedure not related to the actual treatment. But there are some, as Bill was mentioning, there are some intermediate steps that should be incorporated into the clinical outcome. And de-escalation, for example, to me, as a result of a therapy in a study, it's an interesting endpoint.
Ileana.
Yeah, I want to comment on the health outcomes instruments. Even though we have, put in the KCCQ in the Minnesota Living with Heart Failure as reasonable instruments to use, that's for chronic heart failure. None of them will capture what's going on here because you've got patients who can't recall what happened to them 2 weeks ago because they're in shock. So those questions really don't apply. And I like the other battery of tests that I heard, which I think may capture more of the acute changes. So just because we haven't, put them out there, that doesn't mean don't necessarily use them. I think if they've been valid instruments in other settings, it's just that this is a very tough group to capture a health status when we've already said how things are changing hour by hour. It's going to be hard to get there, but I don't think the KCCQ or the Minnesota do it.
Yeah, no, I think your point's well taken, Ileana. You also have, and maybe you can just comment on it, the EuroQol visual analog scale as a potential tool in the acute setting. What, would you comment on that, please?
Sure. I actually like that because it's simple and it just has the patient pick a number, boom. And the fact that you can do it repeatedly because it's easy to do, you may be able to capture how the patient feels as they move from, this stage B, even to stage C, if they can't talk a lot and they can't, communicate a lot, just drawing a line. I like that. It's very simple, but I think it can be captured what's going on with the patient.
I think that's very important. We've used that in a lot of critical care trials, exactly for its simplicity and its ease, especially when you patients either want to refuse the battery of sort of follow-up testing, and that's the quickest thing that they can do. So it's very useful and has been validated. I might just make a comment also for, that on Ron's comment about mortality being important. I think we just want to be cognizant, especially since we're talking about shock patients, and as Mitch sort of summarized it as the acute sort of assault on organ function, is that improving survival in shock with a device or an intervention may be a double-edged sword. So we in the critical care world had this very important trial called DECRA, which was a randomized trial of decompressive craniectomy in patients with intracranial hypertension after traumatic brain injury. And indeed, sort of decompressing these patients' brain and preventing herniation improved survival. But those patients that survive with very poor neurologic function, right? And so knowing that from large sort of surveys of acutely ill elderly patients that there are worse health states than death, like especially if shock has taken hold and caused neurologic injury, just improving survival may not be the best sort of outcome in some of these patients, depending on the populations being studied and the interventions being used.
Yeah, points well taken. And I think, while we're not, at least in this meeting, and perhaps in this first SHARC, attempt, addressing sort of trial design and some of the nuances around creating composite endpoints, certainly endpoints in this field that capture both hard clinical outcomes, but also functionality. I think, using the type of instruments you've demonstrated, in a composite fashion, maybe a hierarchical rank-based approach, an order of severity, of outcome, would work really well here.
Well, again, terrific discussion. Bill, you want to introduce the last session, or you want me to do it?
Sure, and we happen to be exactly on time. So congratulations, guys. You're all doing a wonderful job, and having robust discussions, but helping us to keep this on time. So let's go with our last session, which is classification of safety events for use in shock research. Bill O'Neill, Mauro Moscucci, and you've got your slide presentation. We'll have about 30 minutes for discussion. We'll then have some closing remarks, and we're going to turn you all loose for your weekend. Thanks.
Mauro, I think you're double muted. We can't hear you.
He's unmuted, but it's his mic piece, I think, not working.
Maybe the headset is muted.
Can you hear
No,
me
it's good.
now?
Yes. We hear you now. Go ahead.
Perfect. I'm sorry. So what I mentioned is that I will provide this presentation. I would like to start with this disclosure, where the following information should not be construed to represent FDA views and policies. Similar to what has been done with prior sessions, this effort has focused on leveraging on definition from other academic research consortium and society position statement. We have also been able to coordinate the effort with Ernest Spitzer group on clinical endpoints. And the reason why we try to do that coordination is because there is definitely some overlap between clinical outcomes and safety endpoint. In the next 10 minutes, I would like to provide an overview on standardized definition for death, myocardial infarction, stroke and bleeding, vascular and structural cardiac complication, access-related non-vascular complication, hematologic events, infection, organ failure, and device failure. And then we'll identify current challenges and provide a final discussion. First of all, the first group of outcomes is the death, myocardial infarction, stroke, and bleeding. And we felt that there was no need to repeat or to provide the definition that may not match what Ernest already presented. And so we decided to adopt the same type of definition for death, which include cardiovascular death, non-cardiovascular death, and undetermined death. And because of timing, I will not go through all the different details regarding to each one of those definitions. The same approach has been followed for myocardial infarction with an adoption of the fourth universal definition, a combination of SCAI and ARC2 definitions, and with the addition, as Ernest mentioned in his presentation, of type 5, which would be a periprocedural myocardial infarction. And finally, with this group of adverse event, for neurological event, we have adopted also the same approach with inclusion of NeuroArc type 1, type 2, and type 3 definition, which leads to a further definition of overt CNS injury, covert CNS injury, and most importantly, neurological dysfunction, acutely symptomatic without CNS injury. And again, this definition, both from NeuroArc and also from the VARC3 position statement. And finally, regarding to this group of events, there is the issue of bleeding and transfusion. Ernest provided information regarding to the MCS, the ARC definition. And actually, they're very similar to the VARC3 definition, with the differences that include a fourth and fifth group of adverse event, with the fourth group specific related to bleeding complication in patient with left ventricular assist device implantation. Let me switch now to vascular and cardiac structural complication. I would like to focus your attention on the fact that the current VARC3 position statement includes vascular complication and non-vascular access complication, with both non-vascular access complication, including myocardial perforation or cardiac perforation, but may be secondary to vascular access obtained through a transseptal approach or alternative access to transapical approach. In this case, we decided not to include those and actually to provide a minor modification where there is going to be an inclusion of non-cardiac structural complication, which will include cardiac perforation or cardiac structural damage requiring unplanned endovascular surgical intervention, and with the addition also of atrial septal defect, a major significant left to right shunt QPQ case of 2 to 1 or symptomatic requiring the need of foreclosure. And this is a definition that has been used in the NBARC consensus statement. And finally, there are additional group of complications, which are going to be the minor complication, as is illustrated here. And finally, we have the access-related non-vascular complication. The VAR3 and NVARC divide this complication as major or minor, with major complication including non-vascular structure, non-cardiac structure, perforation, injury, or infection resulting in death, VARC type 2 bleeding, irreversible nerve injury, or requiring unplanned surgery or percutaneous intervention. And with a minor complication, including non-vascular complication in the absence of any one of those additional factors that are listed in major complication. Let me switch now to hematological complication, which may be significant in the setting of certain left ventricular assist devices. For the hematological, for hemolysis, there was a decision to adopt the INTERMAX definition, which are divided into minor hemolysis, defined as a plasma-free hemoglobin value greater than 20 milligrams per deciliter, or a serum lactate dehydrogenase level greater than 2 and 1.5 times the upper limit of normal in the absence of clinical symptoms of fundamental hemolysis or abnormal pump function, and then a definition of major hemolysis with different parameters and associated with clinical symptoms of finding no hemolysis or abnormal pump function, as described here in this list. And also thrombocytopenia was included in the hematological event with a tentative definition based on an acute decrease of platelet count to less than 50,000 per cc. Let me switch now to the group of infection. Infection can be potentially divided in 2 different categories. The first is percutaneous insertion site infection, which of course is included in the non-vascular access complication. The second group is infective endocarditis, with a definition here taken from the SHARC position statement, and defined as positive blood cultures and echocardiographic findings for mass or vegetation only on native valves, ICD, or pacemaker leads. The third group is bloodstream infection, defined as seen here, positive blood culture with no other source identified. And then finally, I included the sepsis. Sepsis is going to be very challenged to define well in the setting of cardiogenic shock. I've included here the third international consensus definition of sepsis, which, as you can see, include life-threatening organ dysfunction caused by a dysregulated host response to infection. For clinical operationalization, organ dysfunction can be presented by an increase in the sequential sepsis-related organ failure assessment, a score of 2 points or more. And now it's obvious that this type of definition may be difficult to apply in the setting of cardiogenic shock or shock, which already includes some of those parameters that may be manifested with sepsis. And finally, there is another group, which is a group of organ failure. Now, I really appreciate Mitch's suggestion that perhaps organ failure can be used as either a surrogate or perhaps more an intermediate endpoint. I have here included the 5 different groups of organ failure: liver failure, acute kidney injury, mesenteric ischemia. In addition, lung failure characterized by refractory pulmonary edema and pulmonary hemorrhage, with pulmonary hemorrhage being potentially an issue in patients on ECMO support where pulsatility may be absent with closed aortic valve and acute left ventricular distension, and they may require venting in order to either revert it or prevent it. For acute kidney injury, we've included VARC3 definition, which I think are fairly straightforward. And finally, for liver failure, there was a definition that has been adopted from European clinical practice guidelines. Again, all this is going to be for discussion. I would like to point out that this type of adverse event or organ failure event are often the reason why mechanical support is instituted. And actually, they could very well, as Mitch has suggested, be used as potentially an intermediate endpoint, has a proof that the device is doing something. For example, improvement of renal function in patients with supported by left ventricular assist devices, or improvement of multi-system organ failure in patients who can then progress to a more stable left ventricular assist device. And finally, there is a group of device failure. This group has been taken from the INTERMACS and the MCS ARC definition. Device thrombus defined as suspected thrombus and confirmed pump thrombus. There is the second group, which is device and cannula migration. And perhaps we can also include in this group of cannula migration accidental decannulation, which unfortunately I've seen happening in my prior experience was part of a Center for Circulatory Support. And finally, device malfunction, which is the major device malfunction and minor device malfunction with the definition adopted from INTERMACS and the MCS ARC, and which are pretty much the same in those two. Like just to close with timing of classification, and this slide matches what Ernest just showed. The procedure has less than 30 days events, acute 24 hours from the index procedure, and subacute greater than 24 hours and less than 30 days after the index procedure. Now, let me now conclude with challenges. First of all, the 2011 ISO 1415 guidelines define an adverse event as an untoward medical occurrence, unintended disease or injury, or untoward clinical signs, including abnormal laboratory findings in subject, users, or other person, whether or not related to the investigational medical device. There is significant overlap between outcomes strictly secondary to cardiogenic shock and safety events secondary to mechanical support. Thus, adjudication of adverse events, device-related versus procedure-related versus disease-specific, might be challenging. Device escalation is not uncommon. This might result in challenges in adjudicating an adverse event to a specific device unless specific states and times are recorded. And finally, it is not uncommon to perform procedure to address or prevent complications. The procedure may then result in additional complication, which provide challenges in terms of how that complication or adverse event is going to be adjudicated and attributed. Shown here, just a schematic representation of overall adverse event. As you can see, within a particular patient, you can have a group of adverse events. Some may be device-related, some may be procedure-related. It's unlikely that you may have, or rare that you may have an adverse event that is both device and procedure-related. The current definition for device-related event is an event that is directly attributed to the device itself. And in addition to that, events that occur as a result of improper use of device are still considered to be device-related. For procedure-related, events that occur from the procedure, irrespective of the device. There are then the shock-related adverse event, which should be ascertained prospectively. And finally, there is an additional potential definition for intervention, which is a secondary procedure performed to address problems that arise as a result of the index procedure, with diagnostic procedure not included in this definition. And again, the challenge is determine what is device-related, what is procedure-related, what may be shock-related. It may be easier to differentiate that within a clinical trial, but it may be more difficult that to be defined, for example, in a registry analysis or in a patient just with cardiogenic shock. I'd like to thank you for your attention, and I think we're open for discussion. Thank you.
Yeah, thank you so much. So let's open things up to discussion. Questions, comments? Mara, you closed with challenges, and one was this challenge of adjudication of device or procedure relatedness, which I think really is a considerable challenge in these sorts of trials. Any approaches that you've seen applied that work For example, I've got experience with some trials that actually do the first, sort of CEC assessment of relatedness, or attempt to do it in a blinded fashion, to treatment assignment in randomized trials. Do you have any experience with this or other approaches that might help add some clarity to determining relatedness of events?
Yes. So my personal experience is based on analysis of some of the report that we received, and also based on analysis of some of the compassionate use cases that have been submitted to the FDA for review after the procedures may have been performed. It all depends on what is leading to that adverse event. Is it a device malfunction? Is something specifically related to the device positioning? Or is it something that is associated with the procedure, but not specifically related to the device? For example, you may have a patient who developed a massive GI bleeding because of an esophageal tear from a transesophageal echocardiogram. There is obviously a procedure-related adverse event. It's not a device adverse event because it's just a component of the procedure that led to that particular adverse event. I don't know if that helped, but again, it's an analysis that needs to be done depending on what type of adverse event is occurring and what is the direct relationship between the procedure and the device itself.
Well, thank you for that. Any other thoughts about that challenge or question, or anything else that was brought up in the presentation?
Bill, I think it's going to be up to the CEC committee to make this determination, but it is going to be very challenging without guidelines, specific guidelines, because as Mauro said, there is the disease, there is the device, there is the intervention. But I must confess that I'm very impressed with the first slides in the first session a few weeks ago that Mitch showed how we dropped the mortality from the disease, but we increased the mortality from the devices or from the intervention. And just because this is a disease that has a high state of mortality, it should not permit you to have any other consequences of device use or be more aggressive intervention-wise. And I wonder what type of criteria you can guide the CEC committee, because it's always going to be a challenge. I mean, the sponsor will say, hey, it's not about us, it's the patient, it's the interventionist, it's the disease. Others may think that the operator will never accuse himself. He'll say this is the device or the patient. So what type of guidelines you would give to the CEC to determine between all those options?
So, yeah, I think this is really, again, a question to wrestle with, but potentially more in the aspirational bucket than we're likely to end. Yeah, obviously, I think in the ARC context, the strongest suit we start with is that the CEC should be an independent body. But building in what's device related, there are certain things that really raise, if you put the device into a location and it has inadequate circulation, so you move the device to a different location, is that a device issue or is that a patient issue? Big cannulas, all those sorts of things. Whereas if the device simply, turns into shrapnel inside the body, that's easier. So I don't know if there are shades of gray that we could paint in. The other reality is that I think device-related failure for ECMO systems and device-related complications for percutaneous systems are going to look very different. So I don't know if there's some broad brushstrokes we could put into this, but I think safety-related, periprocedural safety-related events are going to be, from my point of view, critical to define, and I think you've done a great job sort of laying them out. What are device related? What are syndrome related? What are patient related? That's a taller cliff to climb, probably on this path, from my point of view. I don't know, David, you have thoughts?
Yeah, we're going to have to grapple with it at some point. And I do think that it'll be important for us to be able to provide some guidance. But admittedly, when as we've tried even within our CECs, it's a lot easier in less complicated clinical situations. But SHARC is so messy that it's not easy. I wish I had an easier answer, but I think we do have to tackle it.
Yeah, and I think within a clinical trial, there's always the initial, classification provided by the investigator, and then there is the final CEC adjudication. I think that again, the final CEC adjudication is important. Many, not guidelines, but generally speaking, often when in doubt, people will tend to adjudicate that to the device rather than to the procedure sometimes when there are those gray area. But again, this is all for discussion, and it's definitely a very challenging component of this field.
Maura, I guess one thing that I wanted to at least raise just as we move from this important stage of feedback to the written document is that that was a beautiful and really comprehensive covering of a lot of different areas that we need to think about. Especially thinking from a registry trials and a pragmatic trials viewpoint, there's a lot of detail that would need to be collected in the CRF to meet many of these definitions. And as we move forward, we may need to think more practically in some areas, whether they're simplifications that are reasonable to make and still give viable information, but also leverage the large patient data sets that we may get from registry-based research.
David, I fully agree with you. This is a long list. It's everything that's been put there. Now it's a matter to figure out what should be kept, what should be removed, what needs to be further modified and further simplified. But the goal was really to provide a very comprehensive list that is work in progress. It's like an open slate for further discussion.
Got it.
Yeah.
I'd like to ask Ernst, because you have a lot of adjudication that you're doing in other trials in cardialysis, if you can talk to us a little bit the process or guidelines to the CEC group that works with you. Because before you do that, maybe I'll just give you one example. If you're looking on hemolysis and you know that the device can cause hemolysis and you're sitting on a CEC committee and you see there was hemolysis, you're not going to attribute the hemolysis to the intervention or the disease. But that's maybe a very clear example. So I wonder if you can take all the complications described with the device and see if they appeared, are they related to the device or related to the disease state or to the intervention. But Ernst, educate us how you're doing it at cardialysis. Unmute yourself.
Thank you very much for the question. So basically, we split the processes. We have a safety reporting group and the endpoint adjudication group. Safety reporting requires submitting to the competent authorities or to the ethics committees on a periodic basis this relatedness assessment. So that's relatedness to the device, relatedness to the procedure, and needs to be done with unblinded data. So that's the first consideration. And that's typically done by a safety officer, which is supervised by a physician. In cardiovascular research or in specifically coronary trials that we do mostly, we have an interventional cardiologist approving the reports in relation to relatedness from the safety group. But we typically don't ask the CEC to do the same. So what we are seeing recently, because of the transatlantic collaboration is that some companies, and mainly startup companies, require the CEC to do it. And of course, it makes sense because some of these endpoints are very complex and the devices are new. So that relatedness is generally assessed by the experts in the adjudication committee, but they become some kind of safety reporting adjudication committee, and they need to evaluate these events almost at the time that they occur because of the reporting timelines. For instance, if it's a post-marketing study in Europe, the reporting timelines require that we submit quarterly reports on relatedness. But if it's a regulatory trial, we may need to report within 48 hours or 72 hours. So then we need to have dedicated teams to be available to report these events. So I would say that with the sponsors in the US, it may happen similarly, that there is a group reporting frequently, but then you also have the adjudication committee. And I would be interested to learn when you have the adjudication committee adjudicating relatedness, do they have to be available every time an SAE appears that they need to adjudicate? So that's a very quick turnaround towards reporting.
Okay, I think there is a paper on CEC ARC definition that I know one of my colleagues, Hector Garcia, was involved in that. But again, I think for the SHARC part, it's going to be maybe more complicated because there is a lot of gray zone in between.
Yeah, so Ron, I'm sorry he couldn't make this call, but Don Cutlip at BAME Institute and one of the founding ARC initiators has a very advanced manuscript. I'm pretty sure it's been submitted. That's an overview of device relatedness. And we might reach out to Don. I think, unfortunately, in the shock setting and with both ECMO and percutaneous devices, some of these rules are just going to be novel. But I think it's a real issue. But I think overall, the overall patient outcome is where safety issues start. And then what's related to the procedure, putting the device in versus the devices behaving over the timeframes that Mauro pointed to. I think and what's the device and what's the clinical syndrome in the patient is going to be complicated.
Yeah, I'd like to pose that question to the FDA or maybe anyone who sits on the FDA advisory panels. So let's assume that you have X mortality outcome without any of the devices that has been established in the literature. Now you have a device, you have increase in device adverse events, but the totality of the mortality falls down. So you see more serious adverse events, but instead of X mortality, you have minus X. Would you accept that as a safe device, despite the fact that there is serious adverse events, just because it does reduce the mortality?
Okay, so Ron, that's a great question. And what we would expect a sponsor, this has come up with other devices in other areas, is to utilize the CDRH benefit risk guidance document to make the best case that still we have a positive benefit risk ratio, even with that type of calculus. And certainly it's a difficult decision, but it wouldn't necessarily knock that device off consideration if the benefit of increased mortality could be substantial. The one precedent I might point you to is the original approval of TAVR in the so-called inoperable patient population. Certainly, there was a substantial mortality benefit that outweighed the noticeable increase in stroke rate associated with the first generation Edwards TAVR device. And that's a decision, benefit risk decision that the panel grappled with, but felt it was still appropriate. So it's a hard question that you asked, but one that is not unusual. Is Dr. Farb still on? He may want to further elaborate.
Yeah, Bram, I think you said it exactly on point. And, this is often trade-offs where you may accept a mortality benefit overall, but we can look at the significant adverse events that are related to that intervention and, be able to come up with an assessment of whether it's reasonable to still accept those procedure-related and device-related risks to get the benefit of survival. When we're comparing, invasive devices versus strategy trials to less invasive interventions, we will accept and expect to see more procedure and device-related events. So and often those events help guide further developments in that device and the procedure to lower them in the future.
And if I can comment, Ron, is that the literature has several examples of the use of devices as a bridge to a bridge in patients with multi-system organ failure. The complication may be fairly high, but there might be some organ recovery that can allow progression to a more permanent device in saving the patient life. So there are definitely examples where complications are there, but the final outcomes actually may be much better than without the device.
Yeah, no, I accept all those answers, and these are great to the point. I just would mention, Bram, to your example on the TAVR, I'm sure you wouldn't approve it for low risk at that time. So when you have a plethora of patients or myriad of scenarios and you declare a device not safe, it may be safe relatively for other reasons, or it's not safe, but it may be still used for non-option patients because there is nothing to lose. But that's how you determine that, and how you bring it into an ARC paper. I'm not sure I have the answer to that. So I think we'll have to be creative in writing not only guidance to the CEC to determine about the safety of devices or approaches or strategies that are being using for those patients, but it all goes back to which patients are we targeting the therapies? Are we targeting it to type A, type B, or E? It would be really different. And right now, it's like seems to be going to be generalized to everybody without any specific study. And that is my concern. So we'll have to be creative in writing that section.
Ron, but that's exactly how the FDA benefit risk guidance works. There are a set of parameters that need to be taken into account. One of them, of course, is patient population, it's a magnitude of the benefit, magnitude of the risk. I think it could be helpful in crafting this because, as you point out, what is safe and effective for one patient population may not be for a different one.
Yeah, I think another important part of the safety dimension here, Ron, and the place that it could fit on an ARC paper goes back to Eddie Pfan's, at some point, the patient really matters. And I think the benefit risk guidance that Bram's mentioned opens the door to understanding the patient. If this device, when it does save a life, would cost you a leg or kidneys or whatever more frequently, what's the patient's worldview of that ultimately matters in crafting the benefit risk equation. But to really begin to define that we need better quality evidence than we've got right now. So I think the aspirational bucket, I know I've been a broken record today, but particularly for shock evidence, I think we just have to accept that there are a lot of really important things we're not going to define on the first swing of the bat. That doesn't undermine the value of this document. I'm getting going with the basics of shock evidence, like what is shock and what are the primary outcomes, is a huge contribution. We're going to have a number of things, though, in the more work to do bucket.
You're on mute, Ron.
We have 5 more minutes, so anyone who wants to add a comment or question, please do.
You're still on mute, Ron.
No, I'm not on mute anymore.
Yeah,
We can hear you, Ron.
we could hear Ron.
Any comments from anybody else? Okay, Bill, you want to sum up?
Sure. Okay. Well, I'll keep this really short and sweet. And again, I'll ask, other leaders on the call, to weigh in terms of closing remarks if you would like to. But, first I want to start off by thanking everyone who has participated in this call and is participating in this SHARC effort. Of course, the session leaders and the other individuals that have worked with them to really, draft the proposals that you've seen and heard about and that we've discussed today. But really all of you, everyone on the call who has had and undoubtedly will have input into what the final SHARC document looks like at the end of the day. This really, concludes a very, very important step in this SHARC process. The group leaders and those who have been working with them are going to take everything that they've heard during this session back and consider refinements, revisions to some of the proposals that you've heard today. And that will ensue over the next several weeks, months, and we'll bring this all back together, for a final meeting to develop consensus on the final version that will go into a SHARC publication, so that we can share all of this expertise with the community. So I just want to say thanks again, and Ron, Mitch, Mark, anyone else who would like to make a closing comment, please feel free to do so.
Thanks to everyone, especially the group leaders. It's been great.
Yeah, I may also, not to put you on the spot, but I may also ask Bram from an FDA perspective if you have any summary or closing comments as well as this group continues to make progress.
This has been an outstanding meeting, and the FDA looks forward to continued interaction in this particular forum, Bill. So good job to you and all the other participants. It is very, very helpful to FDA.
Well, thank you so much. Well, I think on that note, Ron, any last words? If not, we'll bring this to a close.
I'd like to thank to everyone. I mean, this meeting was probably the best because there's a lot of work that was done and it was presented. There's still controversy, but the group really delivered a lot. I mean, the next step is really to write it. I'm still in some deliberation, but there was substance here. And again, I'd like to share my gratitude to everybody who participated and shared the session, and to our host, CSRC and Mitch Krukov and all the other partners. And I think we can close on time, 4:34.
Beautiful. Thanks, everyone. Have a great weekend.
Thank you very much.
Bye-bye.